Doctors will start in another 2 minutes. Uh, Good morning, doctors. Yes, very good morning, doctors. I'm Dr. Prabhat, working as medical advisor for Dr. Reddy's Laboratories. On behalf of DRL, I would like to welcome you all to the Regional Nephrology Summit, a meeting of its kind, featuring a multi-module discussion on various updates in the field of nephrology. We are delighted to have the presence of Dr. Rajashekar Chakravarti, Dr. Sridhar, and Dr. P.S. Wali as our course directors for the event. With that, I would like to invite Dr. Rajashekar Chakravarti, sir, to kindly address the audience and set the ball rolling for today's event. Good morning, sir.
Respected teachers and my dear friends, in the last couple of years, you would have seen many posts from Dr. Wali, and I proudly call ourselves now Team Hyderabad. Just like in the sports field, there is Team Chennai, Hyderabad, or any other part of the country. Team Hyderabad nephrology, I am sure, is very unique. And to my mind, the most appropriate quote I can think of for Team Hyderabad is, "As long as I live, so long do I learn." So I believe every day, apart from our day-to-day clinical work, each one of us or most of us have a deep interest in learning different aspects of our clinical work. This being the case, many of us have learned, contributed, been taught, and have taught, and we are here today. You look at the number of publications that come from this team on an annual basis, number of sessions that we are conducting across the country or abroad, or being part of the guidelines that are generated across the world. So I am very proud to be part of this Team Hyderabad. Coming to the Regional Nephrology Summit, this is the second Regional Nephrology Summit supported by Dr. Reddy's. The last one in 2025, all of us have learned very niche areas of our own practice, be it a transplant or the IgA nephropathy or any other relevant topics. So we have now the second edition of Regional Nephrology Summit 2026, and I'm very happy there are two young dynamic course directors who are going to take the entire program with you today, Dr. Wali and Dr. Sridhar, and I'm very happy to see youngsters doing more than us. I welcome all of you, and on their behalf assure you that we will have an academic feast and learn several nuances of how to go through certain aspects of our clinical work. So with the slogan, "Let us learn," I open this particular meeting and request all of you to contribute to the discussion. Thank you very much.
Thank you, Dr. Rajashekar, sir. Now I invite Dr. J. Sridhar, sir, to kindly introduce the chairperson for the first talk.
Peers and colleagues, warm welcome to the Regional Nephrology Summit. And just I want to share this one, like when we were students, like doing DM, options for treating the glomerular disorders are very minimal. Suppose if you take IgA nephropathy, what to give? Only option is, suppose if it is nephrotic syndrome, steroids, or if it is crescentic, just IV cyclophosphamide steroids. But majority of the IgA nephropathy people comes in neither of these. Just we do biopsy, they have IgA nephropathy, some chronicity, no guidelines. Now there are so many new drugs are available, And we are in confusion at the same time whether some of them are, we have learned to use new drugs for the last 3-4 drugs. And some of them are in the pipeline future like Sparsatan, some other. So with this introduction, I invite Chakravarti sir for taking over the session for IgA nephropathy. I invite Dhanlakshmi for... Huh? No? Change. It's okay. We'll start. Yeah. And I... Panel members now? Where they will sit? Where they will sit? Yeah. Okay. That's what.
We'll be talking on IgA nephropathy.
Good morning, everybody. The first sign doesn't look so good. I hope the session goes on well for me. It's not opening. So this IgA nephropathy, as we all know, it was first publicized in 1968 by Berger. And he has described the IgA nephropathy. And since then, we know that it is one of the most common glomerular disease, accounting for around, we know every case, more than 30 to 40% of cases. And this is not a benign disease. It progresses to end-stage renal disease in 2 decades in around 20 to 40% of cases. So, and as we know, this IgA presents in multiple ways, like it could be asymptomatic urinary abnormalities or acute kidney injury, crescent rate, rapidly progressing. Because of this varied presentations, it's actually difficult to put these IgA in a clinical trials and do an activity. And take a note on this slide where just keep in mind where you can see the incidence in Japan, Australia is much, much higher towards the last, Africa where it is very low. Just keep this in mind. So as we know, it's a multi-hit hypothesis where hit 1, there is an elevated levels of circulatory galactose deficient IgA1. And because of this, there is production of specific anti-glycan antibodies which form immune complexes and deposit in the glomeruli, eliciting mesangial injury and scarring. And latest, we also have seen that histological classification for the prognostication and also planning the treatment of further treatment based on the MES scoring, where it includes mesangial hypercellularity, endocapillary hypercellularity, segmental glomerulosclerosis, tubular atrophy, and cellular fibrous crescents. Based on this, they have planned for various interventions. So as finally, the main aim of treatment of IgA is to reduce proteinuria and preserve kidney function. And as Sridhar said, there is lack of consensus about the optimal treatment strategy for this IgA nephropathy. So everyone agrees that supportive therapy is very important, where the blood pressure management is less than 120 and preferred drugs are ACE/ARBs in all patients with proteinuria more than 500 milligrams per day. Calcium channel blockers, non-dihydropyridine are preferred, aldosterone antagonists, beta blockers, and avoid calcium channel blockers, amlodipine and nifedipine. And dietary advice and fluid management, restrict sodium intake to less than 2 grams, control protein intake, and control fluid intake. Lifestyle modifications, quit smoking, normalize body weight, and encourage physical activity. And additional measures are like consider hydroxychloroquine in proteinuric patients and also SGLT inhibitors. So this is the same slide where we used to give fish oils and tonsillectomy also at one time it was advised. And 2 drugs were coming to the play. One is the dapagliflozin SGLT2 inhibitors and one was a dual endothelin and angiotensin II blocker, that is sparsentan. So if we talk about the dapagliflozin, DAPA-CKD trial, in which there were 270 patients with the IgA nephropathy, they were enrolled, whose eGFR was 25 to 75 ml, and urine albumin creatinine ratio was somewhere 200 to 5000. So in this study showed that patients on the dapagliflozin, their primary outcome in terms of ESKD or sustained decline in eGFR of more than 50%. In placebo, it was around 15%, and DAPA was 4. And mean eGFR decline was low in the DAPA group, that was minus 3.5. And albumin reduction, albumin creatinine ratio reduction was also better in the DAPA group. So we can say that dapagliflozin has reduced the chronic kidney disease progression with a favorable safety profile. And the next was the sparsentan. This was a PROTECT trial. In this, it was a multi-centric in various countries. It was done where 404 patients were randomized. In this, the sparsentan group, after appropriate better control of supportive therapy, it showed that at the week, it showed a better reduction in the terms of proteinuria and also in terms of blood pressure. But some adverse events were slightly higher in terms of hyperkalemia and AKI in the sparsentan group. So again, it was concluded that once daily treatment with sparsentan produced meaningful reduction in proteinuria compared with irbesartan in adults with IgA nephropathy. Then comes the steroids. Steroids over time, they have shown that steroid groups often do better, but the recent trial has shown a different view on this. So this year I would like to talk about two trials. One is the testing trial. Testing trial where they have started off with, compared the groups with the steroid and a placebo. In the steroid, initially they gave a very high dose of methylprednisolone, that was 0.6 to 0.8 milligrams per kg. But after few months, because of the very high side effects, they have made it decrease the dose. That is phase 2, they have made it 0.4 to 0.5 mg per kg. And compared to the placebo, they have seen that the results are much, much better in terms of kidney failure. The reduction was kidney failure incidences were very less. The proteinuria has significantly come down, and long-term effects were also sustained. So, next trial is the STOP IgA trial. In this, they have taken biopsy-proven IgA nephropathy patients, around 300, 330, and everyone there was an intense 6 months supportive therapy. That is, maximum RAS inhibition went on. This is a 6 months run-in phase. So after 6 months, they have noticed that without anything, 30% of the patients, the proteinuria has come down to very basic level. So they have eliminated from the randomization. So the remaining patients, they were randomized and compared supportive therapy with the supportive therapy with immunosuppression. So they have shown that proteinuria has significantly decreased in the immunosuppressive group, supportive plus immunosuppression, but the decrease in the GFR was not very grossly different. But there were a lot of severe infections and glucose intolerance, weight gain in this second group, immunosuppression group. But again, the same group, they have observed over the next 10 years. They have seen that the group in which there was a reduction of proteinuria did not translate into the kidney protection in the long run. And around the GFR decline was 2.5 in both the groups, and also the progress to the ESRD was almost the same same in both the groups. Though they have said that the immunosuppression is not translating into the long-term protection in by this study. So now we have two different opinions. So how do you come around this? So if you compare the basic group, in testing trial, they were primarily Asians, China, but this was stop IgA was from the Germany. So baseline proteinuria was also high in group testing group, and that is why they could say, and in this group, the steroids had a good effect. Whereas in the stop IgA group, their profile was different, and the group was different, and they only showed that intensive supportive care alone is sufficient in this case. So conclusion is, this testing and stop IgA in trials are viewed as two definitive yet contrasting studies that shaped modern systemic steroid use in IgA. While stop IgA prioritized safety and intensive supportive care, testing proved that steroids can save kidneys at significant cost in side effects. So hold your thoughts here, and now I would like you to come into a different zone as to why of late we are targeting the gut to treat the IgA nephropathy. So before I come on to the new study, I would like to have a brief basic about why we are concentrating on gut and how is the drug acting on that. So mucosal associated lymph tissue is majorly responsible for synthesis of bulk of IgA. Of that, gut-associated lymphoid tissue covers, it's a major component, and it covers around 200 to 300 meters square in our body. And Peyer's patches are the major component of GALT. It consists of 5 to 200 aggregated lymphoid follicles, and there are 200 to 250 patches in an adult, and 46% are located in the distal 25 centimeters of the ileum. And it serves as a major sites of antigen sampling and induction site. So that ileum, Peyer's patches and terminal ileum is the major site, and it is inductive site. So what do you mean by induction? If you think that immune system was a military operation, the inductive site would be the training academy, where the raw recruits like naive B cells and T cells are first briefed on the enemies, that is the antigens, and they are transformed into specialized soldiers. That is, we can say that they are getting primed. After priming, what happens is, in this environment, the class switch occurs. You know that every time the B cells produce IgM, later on they produce IgG, IgA, and IgA, other antibodies. So that class switching is the major event actually happening there. So after that, when they class switch, they are programmed for homing. That is, they are provided molecular GPS coordinates so that they ensure that once they leave the Peyer's patches, they exactly know where to go, and they have to return to the gut front lines. But what's happening? In IgA nephropathy, there is a dysregulated class switching is happening. So what do you mean by that? In this class switching, instead of the good IgA molecules, we are getting a poorly glycosylated IgA antibodies instead of these protective ones. And also mishoming. Mishoming means instead of coming to the gut, they migrate to the bone marrow and systemic circulation, and they dump these galactose deficient IgA molecules into the blood, and where they form immune complexes. And they are not monomeric, and these are B cell lymphocytes produce polymeric forms which deposit in the glomeruli. So why is this happening? So you have to go back, and that they have labeled as gut-kidney axis. So gut bacteria are not just passive observers here, they're actively modulating IgA class switching. So pathogenic bacteria like Escherichia shigella produce lipopolysaccharide, LPS. And these bind to toll-like receptors on B cells and dendritic cells, and thereby they trigger T cell independent pathway for IgA class switching, bypassing traditional checks. And by this binding also, they downregulate the galactose transferase enzymes. That is, there is a glycosylation errors also happening, leading to B cell to switch to an IgA that is purely glycosylated. So this dysbiotic bacteria also stimulate local cells, that is the epithelial and dendritic cells, to produce powerful B cell activating enzymes, that is BAF and APRIL, that force class switching. And beneficial bacteria ferment fiber in two short chain fatty acids like acetate and butyrate, which act as thermostats for IgA production. So there is a bad bacteria and loss of good bacteria which is happening. So this good bacteria is bifidobacterium, which by fermenting it causes short chain fatty acids and give a healthy regulatory signal. So there is another view also. So first, now we have said that the gut bacteria is stimulating and it is influencing the local immune system to produce a degalactosylated IgA. So there is another view here where there is an evolutionary and ecological view. You know that high-risk population in the initial side, I said, the China or the East have a highest density of these risk alleles. Why? What happened there? In those historically, if you see, these environments had a high mortality from diarrheal diseases and intestinal parasites. Individuals, they had a very hyper-responsive mucosal immune system, and which produced more IgA and had more active B cells, and thus they were likely to survive and pass on the genes. But in this modern environment which is cleaner, the same hyper-responsive genetic profile, which was once a survival advantage, lead to overproduction of pathogenic galactose-deficient IgA. So now that we have seen that it is Peyer's patches or the gut is most important place, now the therapies have come which are targeting that Peyer's patches. So the new steroid, budinoside, is a potent second generation synthetic glucocorticoid which is non-halogenated and has a special 16-17 acetyl group as a thing which gives a special affinity to the receptors and also significant, because it doesn't contain halogens as we see in dexamethasone, it has a significant first pass metabolism and a very short half-life, 2 to 3.5 hours. And the drug which was initially produced was named as Nefecon, is specially engineered with a targeted release formulation. That is, it is designed in such a way that it will bypass the acid environment and only the drug is released at pH of 6.5 in the terminal ileum. The designing is in a way that this budinoside is in the Nefecon, it is opening or it is releasing as terminal ileum. If suppose it's a Crohn's disease, it is releasing the drug in the ascending colon and the ileum. And if it is ulcerative colitis, it will release at the whole colon. So this is the way this drug has been engineered. So that is at the target, it has to be released. So what is budesonide acting? It is binds to glucocorticoid receptors on the mucosal B cells, inhibiting their proliferation and maturation. And the cytokines which I said, that BAF and APRIL, that is B cell activating factor and a proliferation inducing ligand, there is a reduction in these serum levels of these ligands. That is effectively, it is starving the B cells of the signals they need to switch to IgA. And by inhibiting NFKB signaling, it downregulates the inflammatory environment that promotes the excessive class switching. So now we know that this budesonide, the Nefecon, is acting at the site of production and decreasing the production of these pathogenic galactose deficient IgA before they can enter the systemic circulation. So putting in other words, it acts as a molecular brake, lowering the local concentration of growth factors and inhibiting the actual DNA rearrangement, that is class switching, needed to produce pathogenic IgA. So when you compare this with the Visolone, that is systemic, both are anti-inflammatory, yes, but this is the first generation, the other is the second generation. This systemic exposure is very high, around 40 to 60 doses enter full systemic circulation, but In this one, only 10% enters the circulation. Only thing what you have to here is onset of the effect. It is very rapid, which is often seen in within 3 months, whereas here it is delayed. This point you have to note because the significant benefits typically emerge after 3 to 9 months. And the benefits wane very fast, but in budesonide group, it takes a more durable effect. Even after withdrawal of the drug, you can see the effects. So initially in the phase 2 trial, Nefigan was studied where they have said that, concluded that 16 mg is the optimal dose. And in the phase 3 Nefigard trial, this is a pivotal trial which has established the role of budesonide in the IgA. So it is a multi-center double-blind trial in which they have taken patients with biopsy-proven IgA who had persistent proteinuria of more than 1 gram and eGFR ranging from 35 to less than 90 on maximum supportive therapy. So they have seen that initially at 9 months, they have seen that the time-weighted average change in the GFR, this was less in the Neficon group compared to the placebo. Almost we can see a 5 ml difference. And this persisted even after 24 months. So final conclusion was, this study, Nefigard study, has verified the appropriate clinical benefit of Neficon disease-specific treatment that significantly reduced the rate of kidney function decline. So even the same study, the mean change in the UPCR was also quite significant. So if we come to the KDIGO in 2024, they have said that if the IgA at risk for progressive kidney function, they said first is manage the IgA specific drivers for the nephron loss. So first you reduce the pathogenic forms entering the IgA immune complex formation, you reduce this, you add Neficon, and also at the same time reduce the glomerular inflammation with systemic steroids. Later, if you want, there are others, mycophenolate, hydroxychloroquine, and others have been added. Then, of course, the supportive therapy is always there. And the other drugs are recommended based some MMF, cyclophosphamide, hydroxychloroquine, chloroquine, they have been recommended as per the requirement in, like, if it is very rapidly progressing, then use of cyclophosphamide for 3 months. But it didn't show much effect, and mycophenolate was mainly worked up in Chinese population. So towards the end, I would like to conclude that probably it's a time where we have to use the therapy, steroids in 2 different ways. If the kidney is in the hot seat, like a lot of inflammation is going on, you give a short dose of systemic steroids so that if the inflammation in the kidney comes down and we are saving the kidneys, at the same time, probably adding the budesonide, targeted therapy, later on, probably once it will help in decreasing the progression of the disease. Probably this is what I've, thank you so much for your time.
Thank you, Dr. Dhanlakshmi. That was a very, you covered what happened over several decades in the last 20 minutes. Please take your seat as part of the panel. I also request Dr. Swarnalata, please come on to the stage and take a seat as part of the panel. Dr. Sanjay Maitra.
Requesting Dr. Rashika Chakravarti, sir. Yes. Swarnalata ma'am, Dr. Sanjay Maitra, sir. If you can be on the dais for the panel discussion. Sure, sir. No, yes, not.
So, thank you once again, Dr. Dhanlakshmi. It is a topic which I think every day we face patients and sometimes dilemmas about how to go about treating. My first question is to Dr. Swarnalata. What are the latest insights and controversies regarding the hypothesis of IgA nephropathy? Whatever Dr. Dhanlakshmi has spoken to us in very short time.
Yeah, thank you, sir, for covering the entire topic right from the basics to the advances comprehensively. And coming to my question, I think there's a lot of evolution with respect to the 4-hit hypothesis, what Dhanlakshmi has already explained. And a lot of the mechanisms have been enlightened, particularly with respect to how this mucosal the antibodies with the abnormal, what she has mentioned is abnormal switching of the B cells through BAF and the APRIL mechanism. There is a release of what you call as galactose deficiency IgA nephropathy. Normally, it's like, it stimulates the synthesis of IgA, which actually, go to a homing and then they transform into a secretory IgA, what is called secretory IgA. The secretory IgA is one of the important mechanisms for the mucosal immunity. So that secretory IgA, which is normal for, in a patients, that is defective and it leads to a synthesis of what we call galactose deficient, the IgA, which ultimately leads to the antibody formation, the immune complexes. And then these immune complexes get deposited in the mesangium. There's again a controversy about why it has to deposit on the mesangium, in fact. So why the mesangium itself is affected, and there's a lot of inflammation which is elicited and ultimately leading to a fibrosis. There's also a gap in that mesangial cells. But recently, few of the studies have shown that there is something like receptors, transferrin receptors are there in the mesangium, which these immune complex get attracted there. And there's also another molecule which has been described as CD89. I think one of our junior faculty started working on this, looking at these the transferrin receptors in the histopathology and in the serum CD89. So presence of these would probably, explain the pathophysiology of the mesangium being involved in IgA nephropathy. These are the little controversies. I think a lot of research is required at this stage. And as Dhanlakshmi has explained, probably ultimately it is the BAF and the APRIL mechanism. So I think as we have seen, a lot of molecules are coming up to cover all these things. I think in the future, these targeted molecules, that is the belimumab and another is, I think there's some tongue twister. So that those molecules also will be added into the armamentarium of treatment of IgA nephropathy.
Follow-up of that question to Dr. Sanjay Maitra. How does the complement system contribute to glomerular injury, and what are the emerging therapeutic targets in this pathway?
Well, a lot has been talked and has been well covered, but there are certain things which we must address. Firstly, it's a very widespread disease. Secondly, it's a very unpredictable course. Till now, a couple of years ago, we were saying only blood pressure control and proteinuria and GFR is the main criteria. And we were following therapies which were just basically the conservative ones, the RAS blockade and all that stuff. Of late, there has been an explosion in the mechanism which has already been described. Now, sticking to the point of a complement activation, I would like to say very briefly that basically the classical complement pathway has not been playing any important role in this condition. Coming to the alternate pathway, the suspicion is that C3 deposits and the amount of C3 deposits, there is some suspicion that it correlates with the rate of disease progression and end-stage renal disease happening. The second thing is the factor H-related proteins, 1 and 5, are said to play an important part because they are complement regulatory, and there is evidence that if there is any genetic, I would say, change in that, these patients are more prone to have a worse course. Now, the second is the lectin pathway. The lectin pathway has always also been thought to play an important part in the progression of this disease. And basically, this is substantiated by the C4D deposits, which we find occasionally in these patients, and it's being increasingly realized. The third body of evidence is from the thrombotic microangiopathy. A significant number of patients of IgA nephropathy have concomitant or are associated with thrombotic microangiopathy. We were attributing it till date to basically a poor hypertension control. But there is now some idea that possibly complements have a part to play in this. Now, coming to the therapy, basically, as I said, alternate complement pathways play a very important role. And the most important trial till date has been with iptacopan, that is the Applause IgN trial, which was published in the New England Journal of Medicine in 2024. And they showed that 200 milligrams twice a day of this drug caused a significant reduction of the proteinuria. And with this, the FDA gave an approval, and it's being gradually increasingly used. The second drug which is of importance is the terminal pathway inhibitor, the avacopan, the C5a. And this has also been found to be pretty useful in this group and is coming up to the fore. Ravulizumab, excuse me, these are tongue twisters. Basically, the Sanctuary trial is shown that this group would be useful, and in the long run, I am sure we will see more of this. So this is basically the main things which we are. I have to mention the lectin pathway, the mannose-associated serine protease inhibitor 2, narsoplimab, has not been found to be very useful, but subsequent trials are again being designed. So there is a lot of excitement. The problem is we still don't know, and it will only come with time, which ones to use where.
So after hearing...
Have I confused you further?
No. After hearing Dr. Dhanalakshmi's lucid exposition of what happened in the last 2 or 2.5 decades, and both the panelists shedding some light on the different hypotheses for pathogenesis, to the audience, one targeted question. So when you see a biopsy in your hand, the report, and it says IgA nephropathy, how clear are you in your mind that actually you are dealing with IgA nephropathy? Anybody? One of my problems has been, I see IgA on biopsy does not mean it is IgA nephropathy. So I have had patients whom I believe were pure FSGS, but were reported as IgA because there was some IgA on the biopsy. IgA is one of those which can be present in a biopsy for various reasons. As Dr. Dhanalakshmi clearly pointed out, one of the unique things about IgA is it usually does not circulate as a monomer. It actually circulates as a polymer. So because of its molecular weight as a polymer, it gets trapped. So you are all aware, somebody has 5 grams protein loss, some IgA on biopsy, you may treat it like MCD. And we are told that it could be an overlap of MCD with IgA. So you may have a FSGS, you have IgA, you are supposed to treat it like an FSGS. So this has been one of my problems when I see a report and the pathologist will only report what is there in front of them. But your job and my job is to interpret the patient sitting in front of us. So my own take has been, please don't blindly accept every report of IgA as IgA. One of the reasons it's so widely spread or so much incidence is because a lot of non-IgA gets diagnosed as IgA. So with that, the question to Dr. Dhanalakshmi is, what is the diagnostic challenge in IgA nephropathy, and is there a need for a biopsy to diagnose IgA nephropathy?
I can't say, but many a times during our things, if it is only microscopic hematuria, no proteinuria, we never used to biopsy them actually. Probably many cases if we do biopsy, it may come as an IgA. And we never put, just for microscopic hematuria, we never put steroids on them. It was only an intensive thing. But now, given the recent evidences where the gut is playing a major role, and the first step is the microscopic hematuria, I feel probably doing it, and now you have put in a different thing where IgA can be present on a situation basis. But I feel, yes, do a biopsy and target the gut probably.
Well, that was an interesting, I really didn't expect this, but basically the history, primary, secondary, I'm talking of the obvious. If there is a liver disease, there's that's all. Secondary, that we can say. So a good history taking, the context of the whole thing. And coming to your question that biopsy many times gets IgA, irrespective of the morphology, I would say if there is a, forget about crescents. If it is crescent, it's a very significant thing. what is the intensity of the IgA scoring, what is the C3, how much is, how much are they there, what are the other IgM or other molecules which are there, and the clinical course. That is what I would do. C4D, though I mentioned about it, I'm not sure I look at it so much with importance, so I would not get there. But this is, and the MES score, of course. MES score, if your biopsy level is adequate, can be helpful, but I recently read that it's not all that foolproof, and there are problems with that also.
Dr. Chakravarti, can I just
Go ahead.
try to answer the question? The answer lies, apart from the clinical features, which is the most important for any disease, apart from the histology or whatever, what is the clinical feature? That way we are directed to treat the patient. Now, one more helpful pointer in this situation, what you mentioned, is that doing an electron microscopy. If you do electron microscopy, you will see the electron-dense deposits in the mesenchyme in IgA, whereas the podocytopathy will have a different feature, as you know, in electron microscopy.
So we can do, I'm sure many of you may be aware, the traditional teaching, presence of IgA and dominant or co-dominant IgG with enough C3. All three had to be present to make a diagnosis of IgA, of course with mesangial proliferation. So this is a topic which is not as simple, and my own take is that spend a little more time with the patient, look at the biopsy a little more clearly, look at the compartments where the proliferation is and what is there along with IgA. If there is a significant amount of C3, significant amount of IgA, clinical pattern looks like IgA nephropathy, you can label. As far as treatment is concerned, for the first time, we have an armamentarium starting with a simple RAS blockade. You have immunosuppression, SGLT2 inhibition, and downstream even finrenone and other molecules, which are all now cleared for IgA nephropathy. Which to use, which combination to use, to a great extent depends on the patient's presentation.
So can I comment, sir? So, I mean, coming from, I think, teaching institute, I think we have quite different experience, and we have wide variety of presentation, right, from patients with microscopic hematuria, non-nephrotic range protein, because we go for, our threshold for biopsy is less, and then we go for a biopsy. So we have quite a good number of patients with hematuria and non-nephrotic range proteinuria, and as you said, I mean, diagnosis is not a difficult with us because, I mean, our pathologists are well trained and we have clinical presentation, we have clinical suspicious, but most common being IgA nephropathy. And if the biopsy is showing 2+ IgA, predominantly in the mesangium, and with, as you said, associated C3, I think diagnosis has not been difficult. And of course, as the sir said, we have to root out the secondary causes of IgA nephropathy. And still, I think IgA is the most common primary glomerular disease, even in India, in our setup. And of course, treatment all depends upon the clinical presentation, basing on whether it's just a non-nephrotic proteinuria, where we can start with the supportive treatment. And if patient has nephrotic range proteinuria and with the renal failure, we go with the immunosuppression and all other medications.
Can I comment?
Yes, ma'am.
2+ or 3+ is very operator dependent, and it depends on who is viewing the histology. So it's not just enough if you say 1+, 2+. You need to have some comparison to some other molecule. And if that is definite, and if you asked another question, when we should treat. I think you were quoting Dr. Mani's work, where he showed many donors who had IgA in the biopsy, and this led to the concept of trapping of IgA in the mesangium. But if MES score is M1, E1, I think then it is significant and we need to treat. And I'm not sure if, I mean, we miss probably, as Dr. Dhanlakshmi pointed out, we must be missing a lot of IgAs because pure hematuria, even if 4 to 5 RBCs, we tend to ignore and we don't biopsy them. But maybe if we biopsy, we may diagnose more cases of IgA, but whether we call them IgA nephropathy, I'm not sure.
So what Dr. Anuradha was elaborating about was I was part of the unit when this study was done. Every donor's kidney before engraftment was biopsied, and almost 1,000 donor biopsies. Donor meaning when we know that there is no disease, no hypertension. Those days we were not taking hypertensives, no protein loss, no sediment. These normal kidneys were found to have a significant IgA, leading to the thinking that there is a trapping of polymeric IgA. Concomitantly, same time, MMC, that is Madras Medical College, published a data in their in their postmortem biopsies, saying that many of the postmortem biopsies where there was no known disease also had IgA deposits. So these three things left to the understanding that IgA can be there even in normal kidneys. Dr. Pani.
Yeah. Sorry, now that we have the industry partners, I just want to raise an important question here. We are blissfully thinking that the budesonide that we're giving is the same as
It is not the
entry-coated.
targeted one.
And the entry-coated actually starts releasing the budesonide from
different
proximal intestine, small intestine.
We are all aware of that. It is not
I
the
think
same.
I'm just posing the question to Dr. Reddy's whether they have a plan to bring the entry-coated, targeted release budesonide, because we are missing.
So what we and I use today is not the same. Yeah. Dr. Sridhar?
Come with of 70-80%, and ultimately they come with ESRD, and it shows as ESR, like IgA nephropathy. So early when we are picking up in the biopsy, if mesangial proliferation or endocapillary proliferation is there, they should go for immunosuppression. That's what I feel.
Understand. So clinical picture and the biopsy findings.
Biopsy.
Dr. Sanjay.
One brief comment. See, last time I attended this WCN and Dr. Jonathan Barrett had come. What he was saying, which I found very, very strange, even a minimal dose of proteinuria and 4 to 5 RBCs you are supposed to treat. When I asked Dr. Jha, he was appalled. He said, how can you say this? I mean, why are you not treating? I said, but 4 to 5 RBCs in the urine, do you biopsy? So what I understand is nowadays there has been a paradigm shift in the way we treat IgA. So, however, to suggest a sort of pessimistic note, there is data from the literature that in spite of the fact that if you treat, the outcomes are not very different. And the average life in a huge Chinese trial, around a couple of trials, is around, half-life was around, or the end-stage renal disease was at 11.5 to 12 years. So I'm not sure, I'm adding to the confusion, but this is the present data, that whatever you find, even with minimal disease amount of mesangial proliferation, you should treat.
So I think with that discussion, we are clear on few things. Please take a good history. The clinical presentation warrants treatment. Sometimes it is the amount of protein loss, how fast there has been an increase in the creatinine, and of course, you will take into consideration the inflammation on the biopsy also. Once you decide to treat, you look at the spectrum and choose the particular type of regimen that you are comfortable with. One word of caution from my side, please look at, is it some other disease masquerading as IgA? 2 weeks ago, I've had a doctor's relative who was diagnosed 1.5 years ago as IgA. Creatinine is now 3. I got a ANA, ANCA done now, strongly positive ANCA, which was never done last 1.5 years. So this was vasculitis presenting as, and patient didn't get 2 drugs and he was progressing. So that is my word of caution. Thank you very much. I hand over to the next session.
Panelists, just a minute, we have for a token of appreciation, we have small memento. If I request Dr. Rashekar sir, to hand over the memento to Dr. Dhanlakshmi ma'am. Sincere apologies for the technical glitch happened earlier, ma'am. Yes. Next, I would like to hand over the momentum to Dr. Swarnalata ma'am. I request Dr. Rashekar sir if you can handle this momentum. Thank you. Next, Dr. Sanjay Mitra, sir. I request Dr. Girish Narayan, sir, if you can kindly come onto the podium and hand over the memento to Dr. Rashekar Chakravarti, sir. Thank you so much, doctors. Now we will move to the next segment and the next session on very important concern in the practice of CKD, that is constipation. To take this talk, the session would be chaired by Dr. Ratanja, sir. He is senior nephrologist and head of the department care, Banjara Hills. The session would be taken care by Dr. Sirapani, sir. He would be the speaker for the session. I invite Dr. Sirapani, sir, to kindly take his talk on ilobixibat, which is a novel drug to treat constipation with a very novel mechanism of action. Yes, sir.
Thank you, Dr. Prabhat. Having been part of that gut arousing session on IgA nephropathy, I thought we'll go to a gut dormant session, which is this constipation. My experience with elobixibat has been for the last 2 months or so, and I should say it's been moving. Okay. So this has been the big elephant in the room. So most of us are primarily focused on addressing the acute problems of the patients, but a careful history definitely suggests that constipation is a real big problem in our patients. CKD, I mean, a lot of studies have shown anywhere between 25 to 75% of the patients will have constipation as a problem. This, we think, is just a problem that they have to deal with, but it's not. I mean, it's going to significantly impair the quality of life. And also very interesting, until, I'd been researching this, I didn't know that constipation itself can also increase the risk of CKD. It's thought that the uremic toxins can actually enter the bloodstream and cause interstitial fibrosis, leading to chronic kidney disease. And similarly, we know that CKD per se can also worsen the constipation, primarily due to gut dysbiosis and reduced motility. So what are the mechanisms of constipation in patients with CKD? If you look at it, the primary thing, we have to talk about is gut dysbiosis. So CKD, we know, alters the microbiome of the gut, and this leads to overgrowth of certain bacteria that leads to fermentation, that leads to proteolysis of certain amino acids and proteins, leading to excess production of these uremic toxins, primarily indoxyl sulfate and cressyl sulfate. These can have an effect on the enteric neural network and leading to reduced peristalsis. We all know we keep on repeating to the patients, reduce your water consumption because you'll end up in pulmonary edema. And a byproduct of that advice is that they get constipated. They all have a lot of dietary restrictions, especially the fibers which are needed for proper bowel movement are restricted because of excess potassium risk. Medications, we do use a lot of medications that can directly or indirectly lead to constipation, iron supplements, phosphate binders, for example, and opiates, because they can't use NSAIDs, they are on opiates. So these all lead to constipation. These patients are probably fatigued and in eternal exhaustion. Reduced physical activity and sedentary life would worsen constipation. Along with that, autonomic dysfunctions and hormonal changes may also lead to this constipation. So what are the options that we have available at this point that we've been using, mostly a little unsuccessfully, in trying to treat the constipation? So if you look at the bulk forming laxatives like psyllium or methylcellulose, one bigger problem is this have to be taken with adequate amounts of water, without which they can even lead to intestinal obstruction. So that's actually out of question for our patients. Osmotic laxatives, we've been using it for quite some time, and we all like our lactulose, but the patients don't. It's primarily because it's got a pretty bad taste, it's very sort of sweet in nature, and it can lead to a lot of bloating and flatulence. Milk of magnesia is an absolute no-no, especially in late stages of CKD, because it causes hypermagnesemia and related toxicity. Polyethylene glycol has got reasonably safety data in terms of treating constipation in dialysis patients. However, this can also be associated with risks of fluid retention. Stimulant laxatives can be habit formers, and it can lead to something called cathartic colon, and it is discouraged for any patient to be on these drugs for long term. There are these newer agents like lubiprostone and linaclotide. I don't have any experience with this, but there is no long-term data and their safety in the context of CKD. So prucalopride, Pru is the brand name. This can be used in the early stages of CKD, and it does seem to work, but it comes with a black box warning in that, especially patients with CKD, this can lead to anxiety, depression, and suicidal ideation and should be avoided. So this alobixibant has originally been developed by AstraZeneca, and then now Dr. Reddy's and a few other companies here have brought this. And this is the first in class partial IBAT inhibitor. IBAT is ileal bile acid transporter. So I'll just talk about it in the next slide. So we know the liver makes the bile, and the bile gets stored in the gallbladder, and from the gallbladder it's released into the small intestine, and from the small intestine it usually goes through a process of enterohepatic circulation, whereby these IBAT receptors will bind to the bilirubin, and then it goes back in the system. And now by blocking this particular receptor, you're making the bile acids not to be reabsorbed, and they are made to just progress further downstream into the colon. And what it does in the colon is two important things. One is it stimulates the colon for peristalsis. And the other thing it does is it also stimulates the bowel mucosa to secrete more water. So it's doing two things. One is stimulation, and the other one is secretion of water. So thereby it helps relieve the constipation. Okay. So what's the clinical trial data that is available to understand the efficacy of this particular molecule in patients with chronic constipation? So this was the first seminal paper published in Lancet Gastroenterology in 2018, where they did two trials. One is a very short-term trial of 2 weeks. The other one is a trial of 1 year. And all these patients had sort of a significant chronic constipation, and it is categorized by something called Rome 3 criteria. In the first trial, all patients have received this drug for 2 weeks, and this is a placebo-controlled trial. And then in the other trial, it was an open-label, long-term safety trial, and this has included about 340 patients. So what did this trial show? It's very interesting, very important to understand that most or majority of these patients, almost 86% of the patients had SBM, which is spontaneous bowel movement, within the first 24 hours. And 50% of them had complete spontaneous bowel movement within 24 hours. So fecal evacuation is calibrated or sort of assessed by these two terms. One is SBM, which is where they go to the toilet. And the other one is complete spontaneous bowel movement, where they feel that, yes, they have evacuated their bowels completely. So this is extremely interesting. And also, it's interesting to note that most of them had a bowel movement within the first 5 hours after giving the tablet, and a complete SBM happened within the first 9 hours. And this theme continues in the rest of the studies that I'm going to show you, where they have very good bowel movements and they are complete, and the frequency with which they go to the toilet per week has also significantly increased. And typically, most of these patients had less than 2 bowel movements a week, and with the introduction of this drug, it has increased almost to 5 to 6 per week. And this is not just in the first study where it was only done for 2 weeks, but it's also in the trial that lasted for 1 year, where at the bottom graph you can see that the bowel movement happened almost every day of the week, and then the majority of them were complete bowel movements. So that is the quantitative data, and if you look at the qualitative data, whereby what's the nature of the stool, so you know all about the Bristol scoring system, and type 7 is diarrheal illness, and type 1 is extreme constipation, and majority of these people have moved from type 1, 2 to 3 and 4. So that's definite improvement in the bowel consistency. And they also looked at the need for rescue sort of medications to relieve the constipation, and you can see that patients that received Alobixibat needed extremely less intervention to relieve the constipation. So they also did functional studies in patients receiving Alobixibat, and this is by doing what we call as a rectal manometer. So they insert a balloon into the rectum and keep inflating it with small volumes of water, and the volume at which a patient feels the sensation, it's called FCSV. It is called first constant sensation and the volume related to it, and that has actually improved after treating them for 2 weeks with Alobixibat. And then the other measure that they looked at is called DDV, also known as defecatory desire volume, and this has also improved with the introduction of Alobixibat. So what's the safety of Alobixibat? So this trial has been done in elderly patients over the age of 65 and 75, and the quantity and quality of stool frequency has definitely improved, but you can also see the actual adverse events where in the form of diarrhea, abdominal pain, distension, and nausea are actually quite small. It only happens in less than 2% of the patients. So it has also been shown to be safe in patients with a lot of comorbidities like diabetes, renal disease, heart failure, and cancer. But in Parkinson's, there has been definite increase in the incidence of adverse events, and I could not clearly understand why that should be the case, unless it's related to their autonomic dysfunction that they already have. So it's thought to be safe and effective alternative to traditional laxatives. If you look at the absorption of this particular drug into the systemic circulation, is extremely small. So it doesn't get absorbed. There is no renal excretion. This drug is not dependent on renal excretion compared to lots of other laxatives that we've been using. So that's all data relating to general population. So what really happens in patients that are on hemodialysis? So this is a study that looked up patients for a very long period of time, almost up to 4.5 years, and with a median of 24 months. And these are all dialysis patients, and the usual suspects with diabetes and chronic glomerulonephritis. It's the usual representation. But what you can see definitely is the frequency of spontaneous bowel movement has straight away increased from week 0 to week 12, almost from 2 bowel movements per week to 4 to 5 per week. And also the stool consistency has improved across the group. So interestingly, there are a few other things. I mean, some of the other laxatives that we discussed can cause dyselectrolemias, and that doesn't happen with this drug. So the potassiums and the chlorides and the sodiums, everything has remained relatively stable. And the side effect profile is not too bad. So this, I thought, was a very interesting component aspect of this particular medication, where they could really show an improvement in their LDL cholesterol levels. So we kept thinking, why should this happen when you give a drug that you're using for constipation, that it improves the LDL cholesterol? So we all know that bile is made from cholesterol, and each one bile molecule needs one cholesterol to be processed by the liver. And when this is not being reabsorbed and it's being thrown out in the stools, so the body tries to make up more bile, and in the process it keeps using the cholesterol. And also there is increase in the LDL receptor levels on the liver to absorb more cholesterol. So that sort of nicely, it's a nice side, not side effect, but it is a good effect of taking this drug where the LDL cholesterol levels come down. So similarly, this is another study looking at the same thing where they have also shown between a placebo and elobixibad, there is a definite reduction in their LDL cholesterol levels. So what's the evidence for this drug in the Indian patients? So this is a study where they looked at randomized controlled, placebo-controlled study, where they looked at almost 140 to 150 patients. And the same theme I mentioned, there is improvement in their SBMs and there is improvement in their Bristol scores with the use of this drug. And majority of the patients had the first bowel movement within the first 12 hours. So the side effect profile, again, is pretty decent. Only 2% or so had some dry mouth. About 4% had abdominal distension. About 8% had mild abdominal pain. But none of these made the patients to stop using these drugs. So what's the post-marketing and real-world studies of elobixibad? Again, as previously mentioned, the same theme, the bowel frequency increases across, along with the Bristol scoring. So this is another interesting aspect in relation to our CKD patients. So they have shown that after using this medication, there is a decline in the phosphorus levels, serum phosphorus levels, almost from around 5.5 to around 5. And this is thought because the bile will bind the phosphates in the gut and lead to reduction of the phosphorus levels. Not only that, they have also shown that the interdialytic weight gains may actually be better once you start this medication. Perhaps patients don't have the urge to drink much water to relieve themselves, leading to an improvement in their interdialytic weight gains. So in conclusions, I mean, if you compare this particular drug across the other laxatives that are available, it scores on a number of different points. One, it improves the motility and fluid secretion and the desire to defecate. It has got no drug-to-drug interactions, although saying that there are no studies to directly tell us if it's going to have any interactions with some of the drugs that we're using, but it doesn't, so far has not been shown to have any drug-to-drug interactions. It's found to be very effective. Almost 92% of the patients that receive the drug have definitely benefited compared to the next best, which is a PEG. And then almost 86% of the patients will have their first bowel movement within the first 24 hours. And the long-term safety, which goes almost up to now 4.5 years, has shown this to be really not have many major side effects. And if you look at the number needed to treat, it's actually pretty good, which is about 3 patients you need to treat to see the definite benefit in one patient. And it's significantly better than many other laxatives that we've been using. So it's effective, and there is long-term data to show it actually works. It's got dual action, which is one, it stimulates the colon and makes the colon secrete more water. It's established safety in elderly and patients with comorbidities. We have trials from India emanating the efficacy and safety. The dosage usually is given as 10 milligrams, and you can titrate up to 15 milligrams. And it has also shown a byproduct or an advantage in the form of improving their lipids and phosphates and interdialytic weight gains. So with that, I'll stop. Thank you.
Thank you, sir. Now I invite Dr. Ratanja, sir, for the panel discussion. The panelists would be Dr. Shrestha Hussaini ma'am, Dr. Nageshwar Reddy sir, and Dr. Dhananjay Kale sir. If you can kindly come onto the dais. So please have a seat. वहाँ पे रखिए ना.
Good morning. We are all aware of the fact that constipation is a very common problem in Indian patients. Most of the patients feel constipated when we inquire about that. It may not look appealing for the physician to inquire about this aspect for the treatment, but that gives a lot of satisfaction and happiness to a patient who is constipated if treated well. And it has been reported that the overall chronic constipation in the Western world is around 10%, but in India it has been reported that it is higher, maybe 15 or 20%. And patients of kidney disease, as the disease progresses over time, constipation becomes quite a common problem in large number of patients because we are seeing a lot of elderly. So this is almost a kind of universal kind of problem and in most of the patients, and it has to be treated well. Now we have almost close to 6 classes of drugs, besides many other kind of herbal therapies and other Ayurvedic therapies are available to treat such patients, and hence we need to be looking at what are the options and how to use it. And in this regard, I'll ask Dr. Saista Hussaini to explain how does this drug, which has a unique mechanism, different from the other classes of drugs like osmotic laxatives, stimulant laxatives, so far onset and safety is concerned.
Thank you. I have been using this medicine for a couple of months now, to be precise, maybe 2-3 months. And what I found different between this particular drug and the rest of the laxatives, we have different groups like the osmotic stimulants and the other irritant laxatives. This medicine onset of action is nearly just like the meals that we take, associated with the meals in the form of gastrocolic reflex. It takes usually 6 to 24 hours for ilobixabat. And rest of the medicines, sometimes with osmotic stimulants, it takes usually 24 to 72 hours, especially for lactulose and all. And thus lactulose and all, it may cause a lot of flatulence. Patient complains because of the presence of a lot of water retention that it produces. Similarly, with the irritants, the onset may be taking around the same 24 hours, 12 hours. And the patient again may have unpredictable stools. Sometimes in our dialysis room also we see patients, they have a lot of difficulty if they are on dialysis. Apart from that, this is very physiological as per the mechanism of action. Like it increases the bile in the colon, there is a lot of colonic prolonged contractions and motility, the transit time. So it's a lot of physiological that I could say, apart from the rest of the laxatives which are there. Apart from that, the irritant laxatives can cause a lot of long-term side effects in the form of melanosis, coli, and tolerance or dependence, which is not there seemingly. Yet we have to see about the long-term effects of this because the usage is very of short duration as of now. Maybe a couple of years would come to know how it does with our patients. Thank you.
Dr. Nageshwar Reddy, the question is that what is your view about the safety of ilobixabat for the long-term use in CKD patients? Do we have the data that we heard from
just now? Pani has already informed hemodialysis data 4.5 years. Excellent safety record. And the CKD patients, if hemodialysis patients are tolerating without any side effects, we can incur that the CKD patients also it's a better drug. So I have been using for the last 2 months, limited experience, but directly I didn't see any side effects like abdominal cramps or any electrolyte disturbances and all. But the data is there that trial in RRT general, I think renal replacement therapy general, 4.5 years of hemodialysis patients data shows the very minimal side effects. Electrolyte disturbances are also not there, only 4%. No patient was withdrawn from the drug because of the side effect profile.
You were talking only about a side effect, but what was the effect? What did you, in your experience, was it effective?
Effects, personally, see, if you keep, as you said initially, we asked the patient about the constipation, if he will feel very happy. If we keep some drug, if he doesn't tell anything, I think he's happy. So I didn't get any negative response, but if definitely they will tell if it is not working. They won't reveal if it is working.
So the next question is to Dr. Dhananjay. How would you tailor your therapy to identify patients most likely to respond to this bad therapy, the bile acid modulating treatment?
Yeah, good morning, everyone. as rightly pointed out by different speakers, that this drug has been newly introduced. My experience with this drug also is limited. I have been using it since 2 to 3 months. And when I was just reading about this drug, I came across there is another drug called maralixibat, which is also a ileal bile acid transport inhibitor. It is being used in cholestatic hepatitis patients, so for control of pruritus. So in those patients, it has resulted in deficiency of lipid-soluble vitamins, which needs to be looked at, which these studies have not been looked at. Otherwise, it has been a very safe drug. So majority of our patients are chronically constipated. They are been using one or the other laxatives and they are not happy. So in such patients, when I have used this molecule, it has produced good results so far. They haven't complained, as Dr. Nageshwar Reddy said. And what are the sort of patients I am avoiding these drugs are those patients who are having some intestinal disease like ulcerative colitis, Crohn's, or those patients who are having a tendency for alternative cycles of constipation and diarrhea. So in such patients I am avoiding. Otherwise, we have been giving 10 milligram, that is 2 tablets for 5 days followed by 5 milligram once daily, which has been, I think, working pretty well in these patients.
So the last question is to our Dr. Sipani, that ilobixibat should be used alone or as an add-on after we fail the 5 ladders of drugs which are available for treating constipation in CKD. What is your view on this?
I think all the trial data is related to monotherapy, except one trial where they have allowed rescue medication. In this, they combined alobixibat with bisacodyl as a stimulant. So that would be a very short term. Bisacodyl, anyway, we don't want to give it for too long a period. So as a excess, in case if alobixibat alone is not working, bisacodyl, because of its stimulant action, may help to improve the situation. I mean, logically, I can think you can probably combine this with a osmotic laxative, because that would also help to generate more water inflow into the colon and making the process a little bit more swift. But at this point, the data is just primarily with monotherapy.
So ultimately, what we have learned from this talk is that this is a new molecule which has been tried in patients of kidney disease. The dose that is important, that we should not give a half-dose therapy, that is not a 5 milligram to start with. We have to give 10 milligram per patient to experience a benefit before it is reduced. And I think Dr. is raising his finger, so let me ask Doctor to give his comment.
The physician for kidney patients, so I thank Reddy's Lab to bring this topic for discussion, and for any complaint, whatever it may be, they will ask the solution from the nephrologist. So we should know very well how to manage the constipation or any other symptoms. One question to the Reddy Lab directly, that the tablet comes with 5 milligram and they say that take 2 tablets, that's the minimum dose. Why there is no 10 milligram tablet? So that is, I never could understand that. Another thing is that, the question to Dr. Sirapani is that, when you did the trial on dialysis patient, because it causes the secretion of water and because it is relieving the constipation, so was there any difference in potassium level? Because in that case, those who are constipated and you treat it successfully, potassium level is supposed to be lower, mainly so for the dialysis patient. So was there a difference in the serum potassium level for placebo versus this drug?
I think potassium has remained rock steady throughout the period. Almost for 52 weeks they checked, and it hasn't changed.
Because we know that the CKD patients, constipation is one cause for hyperkalemia, and if you relieve it, it is likely to decrease the potassium level.
Yeah, I mean, that's not been seen in the trial data. So I think logically that makes sense, but they haven't shown that.
And on a lighter note, how did objectively the quality of stool was assessed?
I think this is all by patient surveys rather than someone going physically and checking.
Then it is subjective, not objective. Okay, fine.
Sir, to address your question on the dosage part, well, yes, 5 mg was the initial dosage that has come earlier, and several studies have happened on that, and it was found 10 mg to be the effective dose. So now we are planning to come in near future 10 mg tablets soon, sir. But as of now in the market, we have 5 mg. We need to take 2 tablets together at least 30 minutes prior to your major meal.
What was the effect of interrupting the enterohepatic circulation, recirculation? Because you are basically disrupting a normal phenomena. So would you expect some side effect out of that?
Yeah, I think I looked up in this, and there doesn't seem to be any major problems with blocking this circulation, except it helps to reduce your LDL cholesterol, which is not a bad problem.
If I can add to that, it is only a partial inhibition that's happening, sir. Usually 95% of the bile acid get reabsorbed. So we are just partially inhibiting an additional 5 to 10%. It's not like complete inhibition of the IBAT.
Right, thank you.
A word of caution that this drug cannot be used in patients who have got a terminal ileal resection or there is a mechanical obstruction in the colon. So there are few of the restrictions for this contraindication.
I think then, if there are any questions from the house other than Dr. Saha, welcome. So as there are no questions, when we try to treat constipation, this may be an add-on drug for most of the patients because most of the patients will require a kind of fiber diet because low fiber is a common problem in patient of kidney disease. And after the fiber, whatever fiber that we give, we may use osmotic agent with ilobixibat in case patient requires that kind of combination. So I think there are no questions.
Yes,
I thank Dr. Reddy Lab and the other colleagues who have participated in this constipation meeting.
Thank you so much, Dr. Ratanja, sir. And I request Dr. Ratanja, sir, if you can kindly hand over the momentum to Dr. Shaista Hossaini, ma'am, as a token of appreciation from our end. Dr. Nageshwar Reddy, sir. Dr. Dhananjay, sir. Dr. Sirapani ji, sir. And thank you for that wonderful talk, sir. I may invite Dr. Anuradha, ma'am, if she can kindly come onto the dais and give momentum to Dr. Ratanja, sir. Thank you so much, sir. Now we'll move into the next on GLP-1 receptor agonist and its role in CKD patients. So this session would be chaired by Dr. Tarun Kumar Saha, sir. The speaker for the session would be Dr. Joshna, ma'am. She's Senior Consultant Nephrology at Star Hospitals. And in brief, regarding the evidence part, will be taken care by Dr. Arjun from our in-house team. I request Dr. Arjun if you can come onto the dais and take on the evidence part. Later on, Dr. Joshna ma'am would be talking on the management part.
Thank you, Prabhat, for the kind introduction. Good morning, ladies and gentlemen. I am Arjun from Dr. Reddy's medical team. And we at Dr. Reddy's, we are planning to launch a semaglutide, one of the finest molecule in GLP-1 space, like in this year itself, in more than 87 countries in the world, including India. So that is the reason why we want to bring to this table this topic, which is the role of semaglutide and its benefits in chronic kidney disease patients. So we will be structuring this presentation into two ways. One, which will be, first we will be talking about the evidence part of it, and then we will come to the experience part of it. So evidence part I will start with, and later on I will hand over to Dr. Josna madam to share her experience with semaglutide. So coming to the evidence part, so I have structured my presentation into 4 questions. So basically, First one would be why GLP-1 RA is beneficial in CKD patients. That is the number one question. Two, does semaglutide protect kidneys? What are the evidences that we have that backs saying that semaglutide is protecting the kidney? Then, if it does, then how does it do that? What is the mechanistic evidence behind it? And finally, all the benefits that we see with semaglutide, is it only because of the glucose lowering capability and the weight lowering capability, or it is independent of it? So these are the 4 questions which I will try to answer through my presentation. So coming to the first, which is why GLP-1 RA in CKD. So we know that the GLP-1 receptors are present widespread in our body, in mainly major all organs and organ systems, like in the pancreas, brain, heart, stomach, kidney, GI tract, blood vessels, etc. So when these receptors are activated, there are a lot of effects which will happen particularly in each of the organ systems. For example, in the pancreas, it increases the insulin release. It also suppresses the glucagon release and preserves the beta cell mass. When it comes to the brain, it increases the satiety and therefore our calorie intake reduces. In the heart, it will improve the glucose uptake, thereby increasing the myocardial contractility. In the stomach, there is a delay in the gastric emptying time. And in the kidney, they push off the sodium outside, so there is sodium excretion as well as diuresis which is happening. When it comes to the GI tract, it reduces the absorption of dietary fats because of the delay in the gastric emptying, and also this leads to a smaller production of chylomicrons in the blood. Finally, in the blood vessels, it will increase the endothelial nitric oxide synthase activity, which in turn cause vasodilatation, and also it has an anti-inflammatory effect by reducing the tumor necrosis factor alpha and IL-6 mainly, which are the inflammatory markers in our blood. So when these effects are being done, there are a lot of beneficial actions as a part of this effects which is happening. For example, the effects in the pancreas will lead to a good glycemic control. In the effects which is happening in the brain and the stomach will lead to a good weight reduction for the patient. When it comes to the effects in the heart and the blood vessels, it reduces the cardiovascular risk. When it comes to the effects in the kidney, it slows down the chronic kidney disease. And finally, when it comes to the effects in the GI tract and the blood vessels, again, it reduces the incidence of metabolic dysfunction associated steatohepatitis. So this is how the effects and actions are bringing with GLP-1 RAs. So initially, we all know that GLP-1 RAs were primarily researched for the management of type 2 diabetes. But when these actions were discovered and when these actions were actually beneficial to the patient and the outcomes which they were having, so what happened is that the disease areas which were being covered by GLP-1 RA has gone beyond diabetes to obesity, cardiovascular disease, chronic kidney disease, and also MASH. So these are the major indications in which GLP-1 RA is right now being used. So GLP-1 RAs as a whole, if we see, they vary in their molecular structure and in their size, and basically this is divided into 2 broad segments, which is one is the exendin-based therapies, which is basically a protein which is isolated from the saliva of a reptile called Gila monster, which is the protein is called the exendin protein. So from this protein, several GLP-1 RAs were being discovered and were produced, and these were the examples like exenatide and lixisenatide. Then we have the human-based GLP-1 therapies, so which has totally surpassed what was there as the exendin-based. Why? Because it had longer duration of action, therefore the frequency of injection was lesser, and also very low immunogenicity when compared to the exendin-based therapies. So human-based GLP-1 therapies, the examples are dulaglutide, liraglutide, and semaglutide. So these are available in oral form also, which is the one which is semaglutide only, and we have the injectable version also. So when it comes to semaglutide, it is a human-based GLP-1 analog, as I mentioned, and it has 94% homology to human GLP-1. So the rest of the 6% difference is what you see on the screen here. So the 6% difference is like there has been a substitution at this level of amino acid to make it resistant to the degradation of DPP-4 inhibitor. So that DPP-4 inhibitor is no longer destroying this GLP-1 molecule. Second, there is an addition of a fatty diacid chain to this position. So why we have added this fatty diacid chain is because to make the molecule to strongly bind to albumin so that it stays in the blood for a longer duration of time and is not cleared off by the kidneys. So that's the reason why we have the half-life of semaglutide to be of 1 week. So that's long it will stay in the blood for more than a week. So if we look at the complete portfolio of semaglutide, we have 3 formulations: oral, injectable, low dose, and injectable higher dose. And oral semaglutide has been approved for the use in type 2 diabetes and also in patients with type 2 diabetes and established cardiovascular disease to reduce the incidence of major adverse cardiovascular events. In injectable semaglutide low dose, it has been approved for the use in type 2 diabetes, cardiovascular disease, and also in chronic kidney disease. In injectable semaglutide higher dose, it is approved for obesity, cardiovascular disease management, and also the metabolic associated steatotic dysfunction or the steatohepatitis. So we have for this molecule, semaglutide, as the molecule having the highest number of indications in the GLP-1RA in the world. So that's how the indications, and this is the dosage forms which is available. For oral, it is available in 3 dosage forms. One is 3, 7, and 14. And in injectable low dose, it is starting dose as 0.25. Then it has a maintenance dose of 0.5, 1 milligram, and 2 milligrams. Then injection semaglutide higher dose also, the starting at the same dose of 0.25, but the maintenance dose is slightly higher up for obesity, MASH, etc. It is around 1.7 milligrams and 2.4 milligrams. So this is the dosage forms available with semaglutide. Now what about the evidence that we have, the wall of evidence with these molecules? Oral semaglutide comes with a series of clinical trials which has been done called the Pioneer clinical trials, which has shown that there is a robust A1C reduction of around 1.5% in the span of 6 months, and also a very clinically meaningful weight loss of around 5 kgs. And then it has also done a dedicated cardiovascular outcome study, which has shown that there is a significant reduction in the major adverse cardiovascular events with oral semaglutide, and that study is called SOUL study. So this is the kind of evidence that we have with oral sema. When it comes to the injectable low-dose sema, it is also has a kind of a data which is similar that we have seen with oral semaglutide, that it has a good level of HbA1c reduction, a good weight reduction, and also additionally it has cardiovascular benefit, and on top of that it has shown a major benefit in chronic kidney disease patients by around 24% reduction in major adverse kidney events. So that is the reason why health authorities have given the approval for use of injection semaglutide in chronic kidney disease patients. Finally, the injectable semaglutide higher dose has also done a series of studies which has shown an incremental weight loss, an incremental HbA1c reduction, and also a very good cardiovascular benefit. And on top of that, they have shown a beneficial effect in a MASH. That is the reason why they have been approved for the use in MASH patients also. So now, how does GLP-1 produces these benefits in the kidney? So various animal models and tissue models have suggested a variety of mechanism by which it is being done. So primarily, if we see, there are indirect effects of GLP-1, basically which is bringing out by their glycemic control, by the reduction in the blood pressure due to the vasodilation it is causing, and also by reducing the body weight by bringing in weight control, and having been showing an anti-inflammatory effect, it reduces the systemic inflammation and shows these effects. So these are characterized as the indirect effects of GLP-1RA. What would be the direct effects when it comes to the beneficial in kidney? Number one, it causes natriuresis. Second, it improves the hemodynamics. Third, it improves the endothelial function. Then it reduces the local oxidative stress and inflammation. Finally, it inhibits the RAS. So these are the direct effects which has been observed in animal models and in tissue models. If we further look at what exactly the mechanism by which it does is, that if you see, there is an inhibition of this exchanger which is there in the proximal convoluted tubule, which is called the sodium hydrogen exchanger isoform 3. So this exchanger is present in the proximal convoluted tubule, and when it being inhibited, sodium is being lost through urine. So when this sodium is lost through urine, it causes an increased sodium efflux to the macula densa. The macula densa signals to the afferent arteriole to cause vasoconstriction. So initially the afferent arteriole might have been dilated, and because of diabetes or other oxidative stress which is happening in the body, which is causing a initial hyperfiltration in diabetes patients, will get relieved because of GLP-1RA. And it also inhibits the RAS system by reducing the plasma renin activity and thereby causing a constriction of the efferent arteriole. So this will release the glomerular pressure and thereby reducing the albuminuria, and also the eGFR improves. So this is basically the mechanism that we found out when we were studying the animal models and the tissue models. Now what does we have when we see this kind of an evidence? Is it translating to patient outcome? So that was the question at that time. To answer this question, there has been a study which has been done called the FLOW trial. So that is what I'm going to tell about next. FLOW trial is a dedicated kidney outcome trial for semaglutide 1 milligram injection. So what it does is that around 3,500 adult patients with type 2 diabetes and chronic kidney disease at very high risk of CKD progression, they were enrolled into this study. They were on maximum tolerated dose of RAS inhibitors. And some of them were using SGLT2 inhibitors on top of that also, and also MRIs. So these patients were randomized into two groups, one group receiving semaglutide 1 milligram, the other group receiving placebo. So then this was planned to see how they are being on the treatment for the next 5 years. That was the plan. And how and what are the adverse kidney events happening to these two groups of patients. This study was planned, although for 5 years, it did not go till 5 years. The study was prematurely stopped at 3 years because the health authorities have found that the beneficial effect of semaglutide during their interim analysis was overwhelmingly high than the placebo group and the other group. Because this was an event-driven trial, which is around 800 events were supposed to happen. But when the interim analysis was done at 3 years, they found that there are a lot of events happening in placebo group and there were very less number of events happening in semaglutide group. They asked to stop the trial and publish the results, and also they have given the approval to go ahead with semaglutide for CKD patients management. So that's how the story of this FLOW study is. I want to get a little deeper into what exactly the study design and also like what were the key outcomes that we were looking into. So the primary outcome that we looked into was a 50% reduction in eGFR, kidney failure happening or not, a death happening due to a cardiovascular event or from a kidney failure. So that was a composite outcome that was considered as the primary outcome. Then we had the secondary outcomes like the eGFR slope, and then what is the major adverse cardiovascular events, and also death from any cause. So when this was looked into, we also found that when we categorized this patient, 3,500 patients, we can see that more than 90% of the patients fall into the risk category of very high risk of CKD population. And you can see that most of the patients are concentrated in the levels of CKD stage 3 and 4. So that's how the risk category of this patient is looking like. So if we look at one patient, one average flow patient, how does the baseline of a average flow patient looks like? We can see that the patient is like an age of more than 65 years, having an HbA1c of more than 7, uncontrolled hyperglycemia, a long-standing diabetes of more than 15 years, a BMI on the higher side which is more than 30, eGFR also falls into the category of between 45 to 50, and UACR also values high, so it has albuminuria also. Blood pressure on the higher side, and having complications of diabetes like diabetic retinopathy and previous cardiovascular disease, etc. And we can see that most of the patients were already on the standard of therapy, like a RAS blocker, and also 15% of them were also using an SGLT2 inhibitor. So this is a kind of a average flow patient in which semaglutide was introduced. What did we see? We saw that there, in spite of having all the standard of care with them, in spite of having the management which is like a RAS blocker, and on top of that SGLT2, which has proven cardiovascular benefits, it has shown that there is a very significant reduction in the risk of this composite outcome that we were talking about. So that risk was reduced by 24%. And more interestingly, we can see that the risk reduction happening as early as 6 months. So this graph is diverging from placebo as early as 6 months. So it means that not only there is a benefit, but also this benefit begins early in the course of the disease. If we look at the slowing down of kidney function, which also shown that the annual rate of change in eGFR, it is like slowing down by a mean of 1.16 milliliters per minute. So that is also an interesting finding from this study. So it means that the CKD progression is being halted by semaglutide, and a 40% significant reduction in UACR, which is also quite beneficial for a patient with chronic kidney disease. So in fact, if we look at all the primary outcome and the secondary outcomes, flow study has proven superiority of semaglutide versus placebo in all these components, whether it is the major kidney event, whether it is the annual rate of change in eGFR, whether it is the reduction in major adverse cardiovascular events, or whether it is reducing the all-cause mortality. For all the parameters, semaglutide have shown a significant benefit. So semaglutide 1 milligram is the only GLP-1 RA with proven kidney benefits in a dedicated kidney outcome trial. It has provided 24% reduction of kidney disease progression, as well as we have seen that the cardiovascular and kidney death is being reduced, which is happening on top of the standard of care. And finally, it has also proved a proven safety profile and a glucose lowering effect in people with CKD and type 2 diabetes, expanding the treatment option for these patients. Now, the next question which I would like to answer is that now we understood that there is a good patient benefit out of GLP-1 or semaglutide. Now, how does exactly it works in the body or in a patient to show these effects? So there is a study which has been done to understand the mechanistics behind it. So this study is called the remodel study, which is one of a kind study which has been done with semaglutide to understand how exactly all these things happening in the body. So, and the good part is that this study has enrolled patients, around 100 patients, having a baseline characteristic very similar to flow. So we can understand from that flow study has shown this kind of a result or patient outcomes, And now, why these outcomes are being put by semaglutide. So both these together, we will be able to identify what exactly is happening in the body. So this is the study which has been done for that, and you can see this study was in a duration of 1 year. And there is a series of tests which has been conducted throughout the study. Like MRI analysis has been done, there has been blood and urine analysis, there has been kidney biopsy has been done, and also the state-of-the-art kind of a test which is called the transcriptomic analysis, which is basically to understand the RNA transcripts in the cell. So these all analysis have been done throughout the study to make sure that we understand the mechanism of semaglutide to the best. So this was recently published or presented in the Kidney Week conference, which happened in Houston, Texas in November 5th to 9th, 2025. And what we have understood from that is that semaglutide significantly reduced the perirenal fat by a volume of 25%. That's the number one. Number two, it has also reduced significantly the sinus fat, which is there in the pelvis region, by around 13%. So these two fat volume reduction is very beneficial for, as you all know, for a CKD patient, because this is a source of inflammation which causes or which makes the CKD to progress. So by reducing it, finally this CKD progression is being halted. So this is one of the mechanisms. The second is by lowering the kidney vascular resistance. So if we look at the vascular resistance index, which is represented by the renal arterials resistive index, it is shown that semaglutide has shown a significant reduction compared to the placebo. So when the renal hemodynamics is being improved, or when the resistance is being reduced, in the arteries, which is like the arcuate arteries and interlobar arteries, which are the smaller arteries in the kidney, which is mainly affected by the back pressure which is happening in the filtering units, we can understand that the overall kidney health is getting improved when this resistance is getting improved. And then we also shown that in this study that semaglutide has been able to reduce the formation of fibrosis in the cortex. So where this fibrosis formation eventually will restrict the movement of water molecules in the cortex. So when semaglutide has been used, the diffusion coefficient has not been changed after a year's time. So it means that this diffusion coefficient is not getting changed. Therefore, it is like the semaglutide is not improving the hemodynamics, fibrosis formation in the cortex. Finally, the transcriptomic analysis, which has been done with the kidney biopsies, which is also seen that it calms down the genes which is causing metabolic stress, inflammation, and fibrotic responses in the endothelial cells. So all this creates the conclusion that this is the way by which it acts and shows the mechanistic effects in the kidney. Now, the one last point, the question it is like whether this is a effect due to the reduction of the glucose or reduction of the weight. So that where the flow study had an analysis of a mediation analysis, where they have found that when the weight loss mediator was being was adjusted between the groups, what they have found is that even if you adjust the weight loss, the beneficial effect is keeping exactly the same. So it means that the total effect, the observed effect, is equal to the direct effect, which is mediated by the weight loss. So it means that the beneficial effect is independent of the weight loss. So this is how I would like to answer the questions related to how semaglutide is useful for the chronic kidney disease patients in type 2 diabetes. So now, in order to share experience, clinical experience with semaglutide, I would like to invite Dr. Josna Madam, who will be sharing with us how she has used semaglutide in her practice and seen these benefits in her practice or not. Over to you, Madam.
Good morning, everyone. I am Dr. Jyotsna, and I am going to talk about real-world experience of using semaglutide in chronic kidney disease. After such an extensive, detailed description of semaglutide, why it is used in CKD, and how does it protect the kidney, and what is the hemodynamic effect, and which decreases the progression of the kidney disease. We would want to know a little more from the experience point of view. So I came across this molecule. My long-term CKD patient was started on oral semaglutide by an endocrinologist in probably around March, April 2023. At that time, her GFR was around 47 with proteinuria, which was better with ACE inhibitors and ARBs and SGLT2 inhibitors, but she continued to have some amount of proteinuria, but she was pretty obese and having trouble even walking because of her weight, though she didn't have much of osteoarthritis, but her quality of life was limited. Her main complaint at that time for me was she had trouble having because she was taking care of her grandkid, because both the parents were working, and she has trouble running around him. So she was actually started for weight reduction. But that patient, after starting on oral ribelsis, which was started at 3 milligrams initially, followed by 7 and 10, and she went on 14, and she lost like 16% of her body weight in 6 months. And her renal function since April 2023 to now has been stabilized. There's not much of drop in progressive decrease in kidney function. And proteinuria, though there's not much of change, I was limited to add MRAs because of hyperkalemia, because of the RAS inhibitor. But though proteinuria was less than 2 grams, around 1.8 grams, but it's consistent since that time. But GFR decline has definitely decreased, and GFR is more or less the same in the last 3 years. So that case actually helped me to read more about it, and also to start patients on the drug. The only drawback about this drug is about the price. Though starting in 2023, the price was very double the current price. Now the price have come down, but it's pretty significant. I think the oral ribelsis around 14 mg costs around 8,500 or somewhere close to 9,000 per month. A couple of my patients who went on those, they vouch, and they don't want to discontinue it because of the benefits associated with improving the quality of life rather than the kidney function. And they see the creatinine, and they're also happy about it, but mostly because of the weight reduction, better sugar control, and the mobility is not restricted as before, and the quality of life, the fatigue, the weakness, and shortness of breath because of the weight, and also the other metabolic control, it's definitely better than before. So that patient has helped me to start on more patients, but the only problem with this because of the price. And when you talk to the patients, they would want to start the medications at least for a couple of years to help them lose. And some of them want to stop because of the financial implications, but later on they continue if they start gaining weight, again they will ask them for weight reduction. Or even for sugar control, they themselves, when they stop it after 6 months, they will again have a conversation with me whether to start it back or not. But with the recent decrease in price, they have started using a little more than before. This is just a small case snippet. I've used 66-year-old male, obese, with BMI of 34 per square meter, had history of diabetes for 18 years, hypertension, chronic kidney disease stage 3, with bilateral knee joint osteoarthritis where mobility is restricted, and non-insulin along with oral hypoglycemics. The presentation was like uncontrolled blood glucose, worsening kidney function, GFR around 40 ml per minute, has history of hypertension and dyslipidemia. The main complaints for him also uncontrolled sugars, fatigue, shortness of breath, and difficulty in exercising because of the pains and aches. So the diagnosis is stage 3 CKD with BMI of 34 and with comorbidities like diabetes, hypertension, osteoarthritis of knee. This is a patient who requires to go on something for controlling blood glucose as well as for decreasing the progressive kidney disease along with weight loss. So this is a typical example of a patient where some GLP-1 analogs will help with glucose control and also decreasing the progressive kidney disease and decreasing albuminuria along with metabolic control of dyslipidemia, and it decreases the cardiovascular events also, along with the other helpful parameters. So in this patient, GLP-1 analog is a better drug to start it. But if you take guidelines for control of proteinuria, the guidelines like both KDIGO and ADA will recommend using mRNAs, but for better glycemic control or weight gain or metabolic control or improving the cardiovascular outcome, GLP-1 are indicated. I think I will stop with this because lack of time, and
Thank you, ma'am. I may request Dr. Sridhar sir, if you can join us for the panel discussion.
Thank you, Dr. Nair and Dr. Josna, for the nice presentation.
Arjun, you can join the panel
And
discussion.
just a few things before we ask the panelists to give their opinion, the audience to give their opinion, is that in India, we, as of now, are mostly using the oral semaglutide for our CKD patients, as Dr. Josna demonstrated in her patient, or most of us are using. But the trial which has shown the benefit of CKD patients are on injectables. So why the tablet form was not helpful? Was it not analyzed in the flow trial, or it did not find any benefit in the CKD patient? Dr. Garg, Dr. Nair, please, your opinion.
So the flow trial was definitely done with 1 milligram injectable semaglutide. It has never tested oral semaglutide per se. And oral semaglutide, when it has been done that series of studies called the Pioneer studies, there was a study called Pioneer 5, which particularly looked into the CKD patients, and where they have found a trend towards a beneficial effect in terms of reducing albuminuria, as well as like halting the progression of kidney disease. But still, with regards to the fluctuations in the absorption of oral semaglutide, and there is a lot of individual variability. Person to person variability is there. The organizations have not gone forward with testing in a dedicated kidney outcome trial like flow study where injectable
But the
semaglutide.
cardiovascular benefit was evident in the oral drug as also.
Yes, so that SOUL study came, and there was also a subgroup analysis of CKD patients there were also shown that benefit. But when we looked at that benefit, whether it is statistically significant, it did not show that. So that's the reason why they have stopped testing it in having a dedicated kidney outcome trial and go with only the injectable.
Another thing is that if you see the current guidelines for, say, for example, 4 pillars or so, so most of the trial was using a very, only 15% has the SGLT2I, as you only sold from the trial. So is it going to be beneficial on the top of the 3 pillars or 2 pillars? Because most of the trial work with the GLP-1 analog was having a AC inhibitor ARB, but only minority had a SGL2, and there is no mention about the non-steroidal mineralocorticoid receptor blocker. So where do we actually stand in terms of the comparison bit of 4 pillar versus 3 pillar or versus 2 pillar?
Sir, I think the guidelines mention to have SGLT2 in the background first, and then on top of that, GLP-1 can absolutely provide an added benefit because both are functioning.
Yeah, these are from the postulation, from the mechanism of action, or a trial supported comment.
It's a trial supported comment only because in addition to GLP-1, most of the studies, if you look at the flow study, although 15% were on top of SGLT2, when we compare with the other studies like the SELECT study or with the SOUL study which was done, these were all having more than 30% people on SGLT2 inhibitors. So this SOUL study particularly had more than 30% people on SGLT2 inhibitors, and they have found that regardless the use of SGLT2 inhibitors, the beneficial effects are there. But still, the guideline recommendations is what I was mentioning in the beginning, was saying to have the foundational therapy of SGLT2, and on top of that, we can add the GLP-1 to have the beneficial effects in CKD patients by a different pathway.
Yeah, see, the whole idea of poking so many times about this is the cost. Once you add all the 4, your cost goes so much of high. So we need to have a clear understanding the benefit of 3 versus 4, and in taking into consideration about the benefit and the cost ratio. So that is why the whole idea. Dr. Jasna?
I think you can actually individualize, like if you take after definitely ARB plus SGLT2, there's no question about the 2 pillars. The 3rd or 4th pillar, there's a difference between, if there's a very clear guidelines where there's residual proteinuria, then you go ahead with MRAs. And but with seeing the hyperkalemia, like taking hyperkalemia into the context. But for other metabolic like weight, obesity, glucose control, then you add GLP. So in majority of patients, we can decide which one we should go through. But maybe in some minority of patients, we may not be able to. Then it's for the individual discretion.
Dr. Sridhar?
I'm going to be the future anticipation of where you can see instead of 4 pillars, as you mentioned, one is cost, the other is the side effects of hyperkalemia with ARBs and mineralocorticoid receptor antagonist. And any diabetic kidney disease or any kidney disease production, you are asking for first diabetic control, then hypertension control, then all these. When semaglutide, suppose it may be going to be the future first pillar because it reducing the weight.
Before AC inhibitor?
Probably, because probably, at least the reasons I am telling, whatever the mechanisms he has explained, like RAS blockade is there with the SGLT2 inhibitors, weight reduction is there, good glycemic control is there. So it may replace all others in the future, or at least ACE inhibitors, ARBs with SGLT2 inhibitors. No need of, see, if you combine all the 4, the cost will go to, as you said, 15 to 20,000. Suppose in a diabetic nephropathy patient with 1.5 creatinine, if you start all the 4 pillars, 15,000 only for CKD prevention and cardiovascular risk reduction. And how much benefit in terms of preventing ESRD, how many years you are preventing, we don't know. Maybe 3 to 4 years. Instead of that, suppose if based on the whatever that mechanical trial, like the reduction in the fat as well as clinical outcomes, when all the effects are there, probably I think maybe in the future 2 pillars are sufficient, SGLT inhibitors plus air base, so that you are addressing the hyperkalemia issue, you are controlling the blood glucose, and you are, 50 to 60% of the diabetic patients with kidney disease are obese, are overweight. So you are addressing all the issues.
So in my opinion, the greatest advantage of this drug is that diabetes is a metabolic disease, and a diabetic CKD is also that way. So basically, when you have a diabetes and diabetic CKD, you have invariably some amount of a cardiac disease and also a fatty liver. We frequently forget the fatty liver. Now we know that the commonest cause of cirrhosis is fatty liver related. So since this drug has a promise for reducing the progression of fatty liver and also the coronary artery or cardiac disease prevention, but we need to be careful that at what dose it decreases the fatty liver. If we would be lucky if it prevents the fatty liver progression with a little lower dose, because with the dose which is mentioned to decrease the progression of fatty liver is quite high, thereby can create more of a side effect, GI side effect, as well as the cost escalation, cost going much higher. So that needs to be taken care of. So in total overall, considering everything, these drugs may come to be in the second line or a third line after the ACE inhibitor and SGL2I, the third pillar, provided the proteinuria is not a big problem. But mind that these drugs also decreases the proteinuria. So considering the other benefits, it may be in the third or a fourth. So I want the opinion now from few audience. If anybody is interested to pass comment, Dr. Ratan Jha.
What I at least understood from the presentation of Dr. Nair, that this is a drug probably is going to be a good drug in the moment the cost comes down in case it is getting off patent. And this may not be the drug only for treating diabetic kidney disease, it could be also going to non-diabetic kidney disease, because it has many benefits which were attributed to the drug molecule itself. But the two kind of cautions which has to be looked at, because in case the drug is used very rampantly, the two complications which is being talked about in the maybe WhatsApp and other kind of news, etc., whether the drug is safe for eye, particularly maculopathy and loss of vision. And second is the mental kind of disturbance in the form of risk of suicidal tendency that is there, etc. So probably we need to choose the right patient. And this is a kind of thing which is not a black box warning, but this has not been seen in any of the these trials which are there, etc., the randomized trial. But this is in the real world evidence, these things are being reported.
Yeah, I know there's a WhatsApp circulation going on in Australia, some majority, but I don't know the truthfulness of that information. Can you elaborate on that? That there was a lot of suicidal tendency for people who are taking...
Or the suicide.
The suicidal in Australia that is being...
Suicidal, these reports have actually emerged quite high in around 2023. So that time there was some kind of case reports which were published, and therefore a little bit of noise level was created at that time. But maybe after that, what happened is that in 2024, the US FDA as well as the European Medical Association have looked into it. Both the health authorities have looked into it quite deep and found out that from the full database that we are having with semaglutide, and close to a decade-long database with more than 3 million patient data exposure, it has been found that this is not a causal effect.
Yeah, but in India, you know, the suicide may be due to not the drug, but the cost. You know, so leave aside that it's still, you know, unresolved issues.
Yeah. So what
not
happens?
scientifically
What
proved,
happens with that when there is a sudden surge of usage of this kind of a drug within a short window span of period, this kind of effects can pop up. So that what is the probable explanation which has been given by the health authorities.
So, any more comments? Well, I have a few hands, please, Dr. Wali.
Sir, for any drug, I think suicides are overrated, sir. Even when statins when arrived into the market, people talked about suicidal tendency because of statins. And basically, there are multiple papers which link obesity with suicide, sir. Obesity itself is an independent risk factor for suicides. I think.
CKD also. Okay, thank you. We take your point. Madam?
What about the dreaded complication of eye stroke, that is NAION, and which is irreversible?
Yeah, Dr. Nair.
Yeah, so NION, which was published in JAMA Ophthalmology, which states that there is a higher incidence of NION when it comes to the use of semaglutide in people with type 2 diabetes and also in people with obesity. This was actually the conclusion of the paper. But what actually we have to look into is that there are well-established risk factors for NION. Like, for example, the type 2 diabetes itself, obstructive sleep apnea, hypertriglyceridemia, hypercholesteremia, etc. So in these patients is exactly where semaglutide is indicated to. So we are using semaglutide in this group of patients where there is an established risk factor for NION. So that happens, so there is a direct causal relation to this cannot be established through this. And also the study which we are talking about is done in a very tertiary care center in Boston, which actually looks into very complex problematic eye cases. And when they published the data, they were saying that this is a database of more than 100,000 patients. But actually, when it comes to the data, we have seen that it is just a mere cohort of 169 patients with type 2 diabetes and 256 patients with obesity. So this data from a tertiary care center talking about this association cannot be generalized to the total population of type 2 diabetes or obesity, because this is something which is done in a very tertiary care center which is not being generalized to the public. And also this was done in over a six year period. They were seen that this association, how it goes in a 6-year period. And when we seen that after the first year, this association got weaker, and in the 6th year, it got nearly half of it. So that part is also not mentioned. And when we are looking at two groups, when two groups are being compared, we should actually match the severity of the factors in these groups, which was also not done in that study. So there are a lot of limitations.
I think your point is well taken. So if there are no more questions and comments, we close this session and invite the Reddy's Lab to take the handover.
Thank you so much, Dr. T.K. Saha, sir, and the remaining panelists. I request Dr. T.K. Saha, sir, if you can kindly hand over the memento to our speakers and panel members. Dr. Joshna, ma'am. Dr. Sridhar, sir. I request Professor Kiranmai, ma'am, if you can kindly come to the dais and hand over the memento to. Thank you so much. Now we'll be having, as you are all aware, there has been a new ISN guideline that has come on the consensus in the management of anemia and CKD. So we would like, it's our honor to have that inauguration today on the dais, for which I would like to request Dr. Girish Narayan sir and Dr. Anuradha ma'am, if you can kindly come onto the dais and take pleasure to inaugurate this ISN guidelines. we are unboxing the copy for the consensus on the ISN guidelines in the management of anemia. Thank you so much, sir. Thank you so much, ma'am. Just a second. A small token of appreciation from our end. Dr. Girish Narayan, sir, and Dr. Anuradha, ma'am. Small momentum from our side. Thank you so much. Tapas, you would like to add something?
This guideline is just released in this year ISN Con in Lucknow, and we are releasing here also in RNS. So this will reach out to you by next 10 days from our sales team. And DRL has exclusive right of distribution this guideline to all the nephros all across the country.
Thank you, Tapas. To discuss more about the update that has come on these guidelines, I would request Dr. Gangadhar sir, who will be the chairperson for the topic ISN guidelines update. The speaker, Dr. Shrikant ji sir, he is senior consultant nephrology at AI Union Hospital, Banjara Hills. So you can sit over there, sir. Once during the time of panel discussion, you can come. Dr. Shrikant sir, over to you, sir.
So, good afternoon, everybody. I think we are running 1 hour late, so I'll try to quicken up my talk and not cause much trouble. I'm sure a lot of us are waiting to listen to other speakers who are coming up. Particularly, I'm interested to listen to Dr. Wali. He's going to talk about AI adaptation in nephrology. Let's see that. So, the talk I am interested to do today is about anemia of chronic kidney disease, the guidelines from the Indian Society of Nephrology. So these are the societies which are giving guidelines to anemia. As if the residents are not adequately burdened, now ISN has come up with another few numbers, which is now important for the residents to remember for their examinations. So what I'll do is not to stress out too much, talk about how anemia is important in India. These are that kind of things I'm sure all of us understand deep enough. I'm going to only highlight very crisply few points about how ISN has a different perspective of things when it comes to management of anemia when comparing to these 7 or 8 societies which have already given some guidelines. So why do we need? I'm sure we are sure that we are definitely different. Our healthcare delivery systems, our demographies, our diagnostics, everything is different, and I'm sure we need a few things which need to be different from the rest of the common guidelines. So quickly jumping into how things are different, the methodology of developing the guidelines itself is different from rest of the societies. While KDIGO is based on a graded approach with global RCTs providing the grading framework for the guideline, ISN is more of a Delphi method. So what is done? The diverse group of experts in the country are sent are asked their way of managing anemia. There is a structured iteration which has to be followed. They have to fill the form and submit it back. Once they received that, they analyzed it, developed some structure about the guideline, and then sent them back to them again and saying that most people have suggested this, can you correct it or do you want to change it? So that's called the Delphi method process, where the expert consensus is taken, recorrected, and devised until 90% consensus is arrived on a particular point. So once that is done, the guideline has been framed. So it's not based on a deep evidence, but it's based on the practical approach of what is called as a pragmatic approach of managing patients. So the main things that have been changed are, one is the screening for anemia. While it's a standard practice, the KDIGO has told screen for stage 3 to 5 ND at a frequency of 6 to 12 months. Now that has changed. So what they did is, at particularly stage 5 non-dialysis, the request for screening has been made to 3 months instead of the 4 months. That means every 3 months anyway, most of the nephrologists, I'm sure, stage 5, even if they are stone disease or something else, follow up them up every 3 months. And I'm sure we are all already doing this kind of a follow-up when it comes to management of anemia in our patients. The next thing is about evaluation. So how has evaluation changed? So one is peripheral smear has been included as a mandatory initial test. I'm sure all seniors here will agree that peripheral smear is an underutilized test in diagnosing and treating anemia. So it has been made a mandatory initial test, including the RBC indices, microcytosis, macrocytosis. They give a lot of information without actually making the patient spend a lot of money. So this comes most of the times free of cost along with the CBC. So that has been made as a mandatory initial test. The expensive tests like B12, folate are already made into tests which had to be done on a need-to-do basis, based on the peripheral smear examination, or if there is a resistant anemia or a suspicion, it comes under the secondary phase of evaluation. So that also on a need-to-do basis is as part of the evaluation. Also in the secondary workup, the iron panel has to be complete when it comes to ISN guidelines. As we know, the iron deficiency is a very common problem in India. No wonder they have decided to make that as a mandatory test. But the interesting part is about how to evaluate the resistant anemias or the secondary list. So what KDIGO does is to give a other causes approach, which include a lot of things with their primary focus. This was also not done in the original anemia guidelines. In the 2026 KDIGO, they have told that the primary focus of this secondary workup should be on paraproteinemias, endocrinological disorders, malignancies. These are probably more common causes of the resistant anemia in the West. Whereas the ISN focuses on more the domestic problems like worm infestations, malarias, Coombs evaluation, autoimmune disorders, and hemoglobinopathies, which are relatively more common in Asia and eastern part of the world. So their approach to other causes evaluation or secondary workup has been made more region specific, rather than evaluating for paraproteinemias and malignancies as a primary cause. And as you can understand, evaluating these disorders is a little more expensive than what comes into those simpler things which can be more easily evaluated. The next one is about the hemoglobin targets. Now, the KDIGO has told a target between 10 to 11.5 grams, while ISN data had made it 10 to 12 grams. Now, why this difference? Most of the COIR, TREAT trials have compared hemoglobins and given 11.5 as a safe target. But even KDIGO talks that you should not exceed 12 grams. So there is a margin of error there between 11. You should not exceed 13 grams, I'm sorry. You should not exceed 13 grams. So there is a margin of 1.5 grams there which is remaining. So obviously ISN has taken that to its advantage, believing that it is difficult to, it's more easier to go towards the negative side than to the positive side. So it has taken up that margin and has given it 12 grams. And there is not enough data to support as such, but as I told, this is all based on the pragmatic approach of how to manage the problem. Iron deficiency. So the one thing which has been more clearly defined and more easily explained when it comes to iron deficiency by ISN guidelines is to define what is absolute iron deficiency vis-a-vis functional iron deficiency. So what they did is to define a TSAT of less than 20% with ferritin of less than 100 in non-dialysis patients and less than 200 in dialysis patients as absolute iron deficiency. If it doesn't fit that category, it is defined as a functional iron deficiency. Whereas that clear definition was not given by KDIGO. KDIGO was only looking at how to treat the iron deficiency, which are the patients, what are the safer limits until you can give more and more iron. So regarding the iron therapy, so ISN guidelines, particularly for non-dialysis patients. For dialysis patients, there is absolute clarity that the iron should be IV. For non-dialysis patients, ISN clearly recommends oral iron first. If the initial 1 to 3 months period of oral iron does not correct the anemia, then only IV iron can be considered. So that's a ISN mandates oral iron for multiple reasons, including cost, ease of administration. Whereas when it comes to KDIGO, it is IV or oral depending upon the situation. So, and ISN, as I've told, only if the patient is unable to maintain HB at the end of the said period, it is to be considered IV. Whereas in KDIGO, it is either way is fine. You can, if the patient is comfortable, you can start with an IV iron directly. Regarding the preparations, so what kind of iron preparations can be used? ISN recommends non-dextran agents preferentially. Probably the cost of the other non-dextran agents also has come down. Iron sucrose more easily available, more cheaper. But KDIGO is a little vague on that. It includes dextran as an option for management. And hypophosphatemia, which was a relatively common side effect with, or probably uncommon side effect with FCM, is given a lot of importance in ISN guidelines. So what they did is, it specifically mandates a phosphorus evaluation at the end of 7th day of giving FCM. We ourselves are not doing, and I'm sure a lot of us are not following this rule of checking the phosphates on day 7 after administering the FCM molecule, which has now become a very common drug which is administered in dialysis units. So why does mandatory monitoring of phosphate is required? Because of the increased FGF23. FGF and 23 cleaving molecules are inhibited by the glucose component of the FCM, leading to increased FGF23 and what is called as the 6H syndrome. The high FGF23 and the list of other things which are mentioned there are all problems which are quite uncommon, but when it happens, it is quite difficult to manage hypophosphatemia that they develop in these patients. So this is about the 6H syndrome. So that's about the iron. Now, when it comes to erythropoietins and the new HIF-PHI inhibitors, so what is the guidelines talk? The preferred route of administration is clearly given as subcutaneous to safeguard or to cut down on the cost. This is mentioned by ISN, whereas it is IV or subcutaneous when it comes to KDIGO. The dose adjustment between erythropoietins and darbepoietins, the ratio of 200:1 is also clearly mentioned by ISN and is suggested as the route to be taken when shifting from erythropoietins to darbe. Now, HB stability. This is one thing in which ISN has given a little more clarity. So what it suggests is to prevent the HB cycling. So what is HB cycling? That means every monthly or so, whenever you check hemoglobin, the difference, if it is more than 1.5 grams, even with what you presume to be a stable dose of erythropoietin for that patient, it's called as a HB cycling. So when the HB falls, you tend to increase the erythropoietin. Next time it goes up very high, you tend to reduce. So these problems of management of erythropoietin are lesser with darbepoietin. So if you are facing a patient whose HB is fluctuating very much, probably you have to consider darbepoietin. That's what ISN says. Again, these are not based on hard evidence. This is based on the personal belief of most eminent nephrologists. Now, regarding the newer molecules of PHIs, there are two things which probably are very sensible and important to consider in our setting. One is about the cold storage. Erythropoietins require a strict cold storage to be maintained, to be transmitted, to be given, and the patient also has to maintain that at his home to ensure that the drug is effective. Now that becomes challenging in many situations. That is one place where HIF-PHIs have been suggested as an option. The second thing is iron is erythropoietin hyporesponsiveness. Now here also the KDIGO has not clearly, KDIGO is very, even the 2026 update on anemia is not really insisting on HIF-PHIs. and they just say that the role is still being established. Whereas ISN guidelines proactively want you to use these molecules, and it is viewed as a logistical problem solver when it comes to cold storage problems. It is viewed as a problem solver when it comes to iron deficiency. So how in iron deficiency? So this is a hepcidin inhibitor. So once the hepcidin levels comes down, the ferroportin becomes effective, the divalent metal transporters there's easy transport of iron, there's a better transfer in availability. So in fact, even the DREAM trial, which checked the decidustat, has clearly shown that the ferritin levels come down with use of HF-PHI. So what does ferritin levels coming down mean? Ferritin levels are coming down means iron is being effectively utilized peripherally for synthesis of, for RBC synthesis. So probably these molecules have a great role even in managing the iron-related problems and the iron resistance. So I'll be ending my talk with transfusions. So transfusions, again, the standard teaching for us is not to transfuse as much as possible because of risk of allosensitization, which both ISN and KDIGO agree. But KDIGO explicitly states that their leukoreduction alone, so they probably use more of LRBC kind of leukoradiation rather than using those leukocyte filters which are commonly available now. So they explicitly state that even leukoradiation may not reduce the allosensitization because there is enough HLA expression on RBCs and it can still allosensitize patients. So they definitely suggest to, whenever possible, avoid the transfusions, but they explicitly state that just using LRBC is not going to change much about allosensitization. So I end my talk with this quote: the art of medicine is amusing the patient while nature cures the disease by itself. So we are probably, when managing anemia, we are also probably in this situation where we are not able to do enough justice to our patients. Thank you for the patient hearing.
Thank you so much, Dr. Srikanth, sir. If you can please join us for the panel discussion. I may invite Dr. Gangadhar, sir, onto the dais. And session would be joined by Dr. Naveen Kumar, sir, and Dr. Srinivas Rao, sir. If I may request them to please join onto the dais for the panel discussion.
As usual, an excellent talk by Dr. Srikanth, who has done an excellent job in comparing both international guidelines, which were modified or titrated towards the practice in India. So to quick start, actually, I like to ask Srikanth, actually, though the questions are given to me, but I like to ask some few questions to Dr. Srikanth before what are the standard questions are given to me. So do you practice a proactive approach in giving iron in at least dialysis patients versus reactive approach? Is defined in the guidelines? And number two is the dosing to achieve the levels of hemoglobin. Now, how much maximum we can give, because a lot of times we end up giving more erythropoietins to keep that numbers, what you told, the numbers of 10 to 12. So just kickstart the discussion with these two questions, then we'll ask the other panelists also.
Regarding the dosing of erythropoietins, yeah, I think the standard thing is to define as a erythropoietin resistance when it is more than 300 micrograms per kg subcutaneously per week, or 450 when it is given IZ. Our unit uses subcutaneously even for dialysis patients. And beyond that, the idea is to look for secondary causes, including peripheral smears, and then sending them to hematologists for proper evaluation, all the background things. First question, sorry. Yeah, so for that, I think 2019 pivotal study is one thing which has given that iron is not as bad as what people perceive. It is quite safer, and a proactive approach in that study itself, up to 400 milligrams per month, if I'm right, has been safely used without much risk of infections when compared to the general population. And we also use proactive iron therapy in the form of 100 micrograms per week, the standard thing. What makes compliance difficult in the unit is confusing the patient. So what we do is 100 milligrams iron, erythropoietin, 1 dose of multivitamin, because in spite of clear advice, most of them don't take any of the B complexes at home. So making one neurobion or optineuron, one kind of a multivitamin will keep these patients adequately nutritionally well and well preserved. So taking these 3 as part of the first dialysis in the week makes the compliance much, much easier for our unit. I know it may not be the standard protocol, but it makes the compliance better in our unit.
It's a good approach because large number of patients in hemodialysis now. So titrating based on the iron levels, getting iron studies done is also difficult. It is not available everywhere. So if at all it is done, who will see them and who will advise them? That's a problem. So I think whatever approach Srikanth is emphasizing is better, to have a proactive approach in giving iron. Then you also give anyway, erythropoietin is also there, and the multivitamin, whatever the choice is. So among the iron, I like to ask Dr. Srinivas, which iron do you choose now in the current practice?
Well,
regarding the comment on non-dialysis patient and dialysis patient, because the guideline also says about the oral iron. Can you also say a few words regarding using routine iron versus the lipophilic irons, which the latest they are coming to the market?
yeah, I work in a resource crunched situations wherever I'm working right now. So I have a moderate resource crunch for my patients. So in dialysis patients, although the off trend is the patients are asking for FCM, but the cost effective one remains iron sucrose, which even if it is the insurance or the cash paying patient, they prefer the iron sucrose because I have not seen many complications with that, whatever FCM may claim. So in this thing, where I operate at 2 peripheral setups, I use iron sucrose, and only if patients can afford FCM, then I write to them. Otherwise, what happens is the compliance is very, very poor. And I am very skeptical, or at least hesitant in using an IV iron in a non-dialysis setting unless I am pushed to a corner where an oral therapy is not working, or I find multiplier side effects of iron deficiency in other forms, where we have tried everything and anemia is not improving and it's causing other, then I do. But whatever iron IV, to this thing, whatever we say about the safety, this thing, in my setup, I do it under total observation, because even one adverse event is enough to actually create a lot of trouble.
Good answer, because we are also using iron sucrose frequently. So there's nothing wrong in using iron sucrose, which is more cost effective and easy to administer. And what about the irons orally available compared to the routine irons versus lipophilic latest preparations which are given to the market? Are you using them? Or?
Yes, sir. Again, the point comes to the economic affordability of the patient. Not all these tablets, all these medications are not that pocket friendly. We may deliberate how much ever we want about this, but when it comes to a research crunch situations in the periphery, the compliance goes really down. So I have seen whenever I write a drug, the newer variety, the compliance is extremely poor.
So we should also look at the pocket of the patient before we writing the prescription. So I'll ask the other panelists on the type of ESA which you're trying to use. Is there long-acting ESA versus the short-acting ESA? In the long-acting also, like once in 15 days versus once in a month. Which you choose as a therapy when you're treating both non-dialysis and also dialysis population?
Yes. So when it comes to choosing ESAs, obviously there is data telling that all the available ESAs are equally effective, and there are some conversion factors also. So the way I look at it is in dialysis patients, patients usually they receive their ESS at the dialysis unit, and most of them are undergoing dialysis through government policies or insurances which cover for that. So I tend to prefer erythropoietin alpha or beta, short-acting ones, or the analogs in dialysis patients. But when it comes to non-dialysis patients, their logistic issues and cost issues both will have to weigh. Like Sir has already told, the maintenance of cold chain becomes an issue. And if you put them on short-acting ESS, the compliance rate goes down. So I tend to prefer long-acting ones. And with regard to weekly dosing, twice weekly or even 4 times weekly, if we look at data from darbepoetin, there is some data that it is effective even at once in 4 weeks at dose. So what I tend to do is start with a low dose, probably 20 or 40. If the patient is not responding, rather than increasing the frequency, I tend to increase the dose and make it once a month, so that whenever the patient comes for follow-up, they can take the injection there and then itself. The maintenance of cold chain, we can avoid that issue. And with regard to Sera, I don't have much personal experience, and cost is very prohibitive.
I agree with the comments of the panelists. I asked Srikanth regarding the HB cycling that you emphasize in the guidelines. So using short-acting versus long-acting ESA, what is your take on this HB cycling and how it is beneficial to use long-acting ESA versus short-acting ESA?
So when the Mircera was first coming and Roche was introducing the molecule, they had a theme: correct with Neo, maintain with Mircera. That means you correct with the erythropoietin, and then you can maintain with a long-acting cycle. I think that was around maybe 10 years ago when they were proposing this. I think that is what is probably the right thing to do, because erythropoietin, the way erythropoietin corrects, the long-actings may not. That's not my personal experience, but that's what is theoretically. And it's that HB cycling is a common problem which is seen in our units. And particularly once the hemoglobin crosses 12, and you say, like what Sir is telling, monitoring everybody becomes difficult. It crosses 12 or 13, you say them to stop, and then you see them say 2 months later, again their hemoglobin is 8 grams. So they would skip doing the hemoglobin next month because they believe everything is okay, there's nothing to do. So that's why I think long-acting erythropoietins have definitely a strong role, because it makes it compliance easier, and maintenance, this HB cycling errors are less likely to happen with this.
So I have one question, sir, over here. So considering the guidelines, the previous guidelines, which have come long back in 2013, and then the initiation of darbepoetin has come into the market. So in these new guidelines, they have clearly mentioned that apart from the
Yeah. So, my dear friends, colleagues, seniors, the title of this, let's have the next one. The title of this talk is supposed to be Work-Life Balance Among Nephrologists. Is it a myth or reality? I'm going to remove the suspense right away. It's a myth. It doesn't exist. For us nephrologists, there's no such thing as a work-life balance, because work will always push into our personal life. And you've all seen it together, all of us have seen it. You go for a movie on a Saturday night with your family, say you go for Durandar 3.5 hours, and then the family is sitting inside and enjoying the movie, you're sitting outside in the foyer answering calls from the hospital. Okay, this patient has got this problem, this got that one, what do we do, and you missed half the movie. You go to a party, and then you will, the minute somebody finds out that you're a nephrologist, they will come up to you and say, sir, we just want to disturb you a little bit. My son is 5 years old and he's still bedwetting, what do we do? My father is on dialysis. Have both kidneys failed, or is it just one kidney that has failed? This happens on and off all the time. And it's a Sunday afternoon, you have had lunch with your family, you're all set for the siesta, and then you get a call from the transplant coordinator saying there's a cadaver kidney available. Can you come and please talk to the family and counsel them, and then you have to go there and prepare everything, and then that's the end of your Sunday siesta. So there is no such thing as a work-life balance. So what happens here? If you don't have a work-life balance, what is going to happen to you? You're going to get lifestyle diseases. And by lifestyle diseases, I'm talking about diabetes, blood pressure, cardiovascular disease, cerebrovascular disease, metabolic syndromes, malignancies. And the end result of all this is what? You're going to die early. the statistics are, in the urban population, 70% of people die of lifestyle diseases. That means 7 out of 10 of us over here in this room are going to die of a lifestyle disease. Is there anything you can do about it? Yes, there is. We'll come to that later. Another scary statistic I want to share with you. Does anybody know the average life expectancy of a doctor in India? Anybody? Absolutely right. 55 to 62 years. And the average life expectancy of a normal Indian male today? Exactly. 65 to 72. They live 10 years longer than us. We are supposed to be knowing how to live longer than them. We tell them how to live longer, and they live longer than us. Why? Because of stress. We don't have a proper work-life balance. And stress, why? Financial stress, work stress, we don't eat on time, we don't exercise regularly. All this builds up, and we are all likely to die faster than our patients unless we do something about this. Now, the first mistake we make, which all these lifestyle gurus and motivational speakers and all tell us, they tell us that work-life balance is a straight line, where you have your life, your personal life in one hand and your work in the other hand. Remember, geometrically a straight line will never balance. It's going to tilt based on the weightage you give on each side. How do we solve this? Next one. You convert this straight line into a four-sided figure. So, you have your work as one side pillar, your life as the other side pillar. Your base should be medical health. By medical health, I'm talking about diabetes, blood pressure, weight control, all those things. Because if you don't have your medical health in place, you're not going to have a balance anyway. And the top layer, the most important layer, which is what I want to focus on today, is exercise and diet. Exercise and diet go hand in hand. They're complementary. You cannot have one without the other. So you cannot expect to outrun a bad diet, nor can you expect that if your muscles are tight, then if you eat right, your muscles will get tight. No, you have to have both complementary. And for the rest of this talk, I am going to tell you how to find 1 hour in a day to do your exercise, and that is going to improve your lifestyle, that is going to keep lifestyle diseases at bay, and that is probably going to make you live longer. And whatever I'm going to tell you is based on personal experience. It's not something that you will find in internet or Google or ChatGPT or whatever, Dr. Wali. So this is something which is personal, which I have applied in my own life, and I've seen the effect of that. The first thing to remember, get out of bed thinking your day has 23 hours. The minute you get out of bed thinking your day is 24 hours, it's gone. So get out of bed thinking I have only 23 hours to do everything, do my personal life, my work, my whatever, and then you will find that 1 hour to do your exercise, and of course complement that with the diet. Now there are certain hacks where we can help get that 1 hour of time. One, do everything at the same time every day. So each task that you do, the mundane task that you do, if you do it at the same time every day, you will find that with repetition, it becomes more efficient, and you'll be able to do it in shorter period of time, and you'll slowly get 1 or 2, 5 minutes here, half a second there, and then totally you can get that 1 hour. Other hacks I will tell you as we move on. We will now look, right. Now, whenever we talk about exercise, we talk about warm-up, because the minute you start doing any kind of exercise without a warm-up, you're going to get into trouble, you're going to pull something. So, even when you talk about exercise, we need to do warm-up. So now, can we all stand up? We're going to warm up while you listen to this talk. I want you all to forget that you are seasoned nephrologists, very distinguished, you are very sober, you are very solemn. No, I want you to get back to your childhood now. I want you to have fun. This is a fun session. I want you to enjoy yourself. And I got Dr. D.S. Rana to do warm-up in Delhi recently in one of these conferences. So, yeah. So, the key to warm-up is going distal to proximal. Okay, and we'll have some music while we're doing it. So, let's start. Just follow me. I'll make it short. Come on. Start. No previous one. Okay, let it be. Yes. Good, Dr. Krishnan, come on. Yes. Now this. So we're going more proximal. Okay. Yes. Other way. Next. Okay. Now bend forward. Yes. Very good. Lower legs now. Okay. Now cross. Yeah. Good. Across the. All right. Perfect. Please sit down. This has to come again. Okay, now a fun fact for you. Whenever our hands cross the midline, our attention span increases because the corpus callosum sends signals right across. Both cerebral hemispheres are activated whenever you cross. So when we do this or when we do this, your attention span increases. And eureka moment for me, now I know when my first standard teacher made me do Murga, I knew why it was being done because I was not paying attention, and that made sure that I paid attention. It's all pure science. But since all of you are so, involved in this and you took part in the warm-up session, I'm going to give the most sporting person a gift. And I think, in my opinion, the most sporting person is Dr. Krishnan. So, sir, you think I can reach there? Yeah. For being so sporting. Thank you. Sir, can you open it up and hold it and show them what it is? So that is a motivational diary which I have created, and it will help you go day to day. It will track what you're doing and help you to move on and then do more things as much as you possibly can. Okay, so it's okay. You can show later. Shortage of time. Now, when we're talking about exercise, there are 4 major hurdles that we come across. Lack of interest, lack of motivation, lack of knowledge, and lack of time. There are others also, but these are the most important ones. So lack of interest, how do we get over this? You club exercise with something which is interesting. See, nobody likes exercise. It's painful, your body hurts, this, that, but you have to convince yourself that what you're doing is fun. So one method, I'm going to tell you what methods I use. One method is music. When you listen to music, you club it with exercise. If you like listening to music, you won't even realize that it's exercise that's happening. Or you can do brainstorming. What I do is when I'm on the treadmill, I think about all the patients that I've seen today, what investigation I'm going to do tomorrow, and if this turns out that way, what will I do? If this investigation comes this way, what will I do? You can also make presentations. While you're on the treadmill, you decide how the flow of presentation is going to be, and then you can just apply it when you go back. And if you're studying for an exam, you revise whatever you have read through the day, so that's all out of your mind, and then you go back and you read the next topic. This is what I did when I was preparing for my DNB exams. And this is all something which I've done personally, and it has worked for me. That's the reason why I'm sharing it with you. Now, how many of you like to exercise? Oh, that's a good number. How many of you like music? How many of you like listening to music while exercising? Yeah. So, we are doctors, we're scientific people, right? I'm not going to take this as face value. Unfortunately, there are no randomized controlled trials to tell us how music helps you to exercise well. We will do an observational cohort study over here. But before that, can I have the hand mics here? Before that, I want to come across to you and ask you how all these people who raised their hand when they said that they exercise with music, I want you to tell me how it helps you exercise. How does music help you exercise? Anybody wants to give me an answer? A good answer gets a gift. That's motivation enough. Lack of motivation? Anybody wants to tell me how music helps you exercise better? Nobody. But why did you put up your hands then? I think you put up your hand. You should give an answer now. You're forced to. How does music help you exercise better?
No, in fact, we don't realize that we are doing exercise, and it gives us the comfort. And it's already 1 hour over by the time we have finished. So, it's...
Perfect answer. Yes. Anybody else see? Dr. Saha. Say it into the mic, sir.
Rhythm of music and rhythm of movement. If you can synchronize, it helps.
Yes. So that's why if the music rhythm is faster, you do a little faster. Anybody else? Sir?
Yeah, is one way of releasing endorphins inside. No.
Perfect answer.
Positive feedback to improve your workouts and this one.
Positive feedback.
It enhances your.
Yes? Yeah. Complete the sentence. Okay. Yeah, so we got 4 answers. Anybody else wants to say something? Okay, now I have to decide the 2 best answers from this. I think Dr. Saha's answer is good. Sir, rhythm. It keeps up the rhythm. Skipping. All right. Right, sir. So this will help you exercise.
Why are you changing the gift?
Because rhythm.
Thank you very much. Thank you.
So see what it is. That will help you exercise. And I think Swarnalata ma'am's also answer was good. So now we're going to do this. This will help you exercise better, ma'am.
Thank you.
So we're going to do this observational cohort study. Play the same thing. Okay, wait, not yet. So let's do, whoever wants to, stationary jogging, come on. Come on, stand up. All the youngsters here, come on. Forget you're all nephrologists. Yeah, sir, you can sit. You early, anyway got your gift. Yeah. It's getting boring, right? We're getting tired, legs are paining, breathlessness, and discomfort. What do we do about it? Can we do something about it? Something changed? Feel better? Yeah, that's it, better. The rhythm, sir. It made a difference, right? It made a difference. So all the points that you raised are valid. There's one point which I want to add myself. The biggest demotivating factor while you're exercising is the sound of your own gasping. The minute you hear that, your brain gets a signal saying, boss, you're tired, stop. And you stop. What music does is it eliminates that sound. You can't hear yourself gasping if the music is loud enough. And so you think, I'm not tired, you can go on for more and more. It's all about fooling yourself. So this is how music helps you to, apart from all the other reasons, and this you will not find anywhere. This I learned over the years. As I was exercising more and more, I realized the louder the music, I could do more. I realized it was helping me because I wasn't hearing myself gasping. So lack of interest. So utilize this method. I wanted to play the same song next time also. Utilize this method. Next is lack of motivation. I can't buy this because we are all super motivated individuals. We would never have reached this level that we have reached if we were not motivated. The problem is we don't direct the motivation in the right direction. And you need to motivate yourself to direct it towards exercise. Only then it's going to happen. And one motivation is I see so many of you smiling and laughing, right? Why are we smiling and laughing? Why are we enjoying ourselves? I'll give you a mnemonic. We're so happy. We like mnemonics so much. Like you got your dose of happiness because of exercise. D-O-S-E. Can somebody tell me what D-O-S-E stands for? Endorphin, enkephalin. Perfect. You deserve something for that. Come. Skipping rope. Yeah. Get the diary. So this is a T-shirt.
Thank you.
I hope why don't you open it and show it to them? Again, it's designed by Dr. Homo Sapien. I hope it fits. If it's not, let me know. Just hold it up for them. So there's more to be won here if you're interested. So yeah, motivation. Again, let's prove it. I need 3 volunteers. 3 of you, anybody, I want you to come up and do planks. Anybody? Come on here, just come and have fun. Don't be so... See there, he's already getting it ready. Oh, you're coming, ma'am. Come. Wonderful. If nobody else comes, then she's hands down winner. There's a prize for the winner, by the way. So you want to win a prize? Come. You'll be able to do? I'm sure. I'm sure. Okay, yeah, Sirapan is coming. Come on. Oh, yes. Okay, so we have 3 competitors. And let's see how much each can do. He's already given up. He's saying, Madam is sure shot winner. So I'm going to put the timer on. I'll tell you when to start. Start the music again, the same one from the beginning, but... No. Yes. Okay, wait, let me start the timer. Okay, come on. Once you're ready, I'll say, okay, time starts now. I've started. Yeah, I want you to cheer them, come on. Come on, ma'am. Fantastic. Come on, guys, cheer them. They're all rock steady. 1 minute. Wow. Nearly 2 minutes. It's unbelievable. And nobody looks ready to give up. Come on, Pani, keep Apollo Hospital flying. This is phenomenal. Can anybody do this? 2 minutes, 2.5 minutes? Don't give up, don't give up. Fantastic. They don't want to give up. Nobody wants to give up. 2.5 minutes. Oh, they're doing some manmani in between. You give up first. Ah, well done, well done. Fantastic. 2.5 minutes. Wait. Don't look at each other. 3 minutes. The song is going to get over, but they're not getting over. I hope all this is being video recorded. We won't put it up on Facebook or Instagram though. 3.5 minutes. Oh! Okay, ma'am, you're the winner. You're the... Fantastic. Ma'am, let me help you up. Oh, you don't need any help. Wow! I mean, talk about woman power. 3.5 minutes. Come onto the stage.
My best performance was 5 minutes.
Wow. Because he gave up, you gave up, right? Otherwise, you would have done 5 minutes easily. And you know, all 3 of you deserve a gift for this. Ma'am, this is for you.
The second gift.
Yes.
Thank you.
There's more to be won. And Excel will be okay for you, no, sir?
Yes.
Yeah, it should be. If there's a problem, let me know. We have other sizes. Fantastic. You know, with great difficulty, I can do 2 minutes on my own. They have done 3.5 minutes. I'm sure. Chirapani, have you ever done in your life 3.5 minutes of plank? Never, no? So that's it. I mean, I've proved the point here. Competition motivates you. So have little competitions amongst yourselves. So you know how many steps I can walk today, how much planks I can do, how many crunches I can do. All this will help you motivate yourself and help you to do what you are supposed to do, that 1 hour of exercise on a regular basis. By the way, fun fact, do you know the world record for planking? No. Yeah, close to that. It's 9 hours 38 minutes by somebody called Joseph Salek, and he did it at the age of 54. The record for women is 4 hours and 30 minutes by somebody called Donna Jean. She did it at the age of 58. So, of course, we are not going to aim for all that. I think ma'am does 5 minutes. That itself is phenomenal number. I cannot do 5 minutes, and I've been exercising for more than 30 years. So, but yeah, lack of motivation. The next hurdle that we find is lack of knowledge. Again, I cannot buy this because we are doctors. We have studied anatomy, we have studied physiology, we know which muscle moves which joint. And these gym trainers, they have a 6-month training and then they come and they really don't know anything. In fact, I have forgotten more about muscle movement and exercise and joints than they've learned in their entire life. So, just to understand, can I have somebody who will demonstrate how to do biceps? Come, anybody who can demonstrate how to do biceps. Naito, I'll get one of these Reddy's guys. You want to compete with them? Anybody wants to come up and demo biceps to me? If you do it right, you get a gift. Motivation. Hey, one of the young guys, some young guys there. Come. Come. Yeah. Don't be hesitant or shy here. We are all friends here. And they're not going to give you less marks if you come and show them how to do biceps. So come here. What's your name? Lalit. Lalit. Okay, Lalit. Please demo to us how to do biceps. Music.
Do like
Mic. One second. Where's the mic? Yeah. So I'll hold the mic. You show.
Don't do whole extension. Little bit extension should complete extension should not be done, and you have to complete flexion you can do with the biceps.
Okay, almost right. Just wait for a couple of minutes. So basically, whenever you exercise any muscle, the key is to be relaxed and also to make sure all the other joints are fixed. So if you want to exercise biceps, you're only doing the elbow joint. So you don't want to be doing this, or you don't want to be doing this. So you need to fix this joint. The way to fix it is keep it against your body, be a little relaxed, and like he said, never the full extension, just about maybe 10 degrees, and that's simple and easy. Don't go for heavy weights, because if you do heavy weights, you'll do this, or you'll pull some muscle or you'll injure yourself. So light weights, more repetitions, and your trick is done. There's your gift. Go back and do the bicep. So lack of knowledge again is something which I cannot buy. Basically, we know everything, we just need to apply it. So look in the mirror and make sure you're doing it the right way. And now the final point, the final biggest hurdle, people can write books on this, lack of time. Come. Okay. Now I have created a matrix. Next. I have created a matrix called the Homo sapien time matrix to find that 1 hour of time that you require mandatorily every day to exercise. Part of the hack I already told you, believe your day has only 23 hours. So that 1 hour, do everything at the same time every day, you will get some time. And prioritize the things in your life. This time matrix only works for your personal life. Work, all the other things are not part of this time matrix. So you divide things into just 4 quadrants. Things that make you happy, things that do not make you happy, things that you can give up, and things you cannot give up. I'll give you examples for each. And you have your own life. You have your own quadrants to fix and decide how you want to fix them. So say, for example, music. Music makes me happy. So I cannot give up on it. It makes me happy. I will do it. How will I do it? I listen to music while driving, I listen to music while reading the newspaper, I listen to music while exercising. If you like watching TV, you watch TV and exercise. Like I watched the first 6 overs of 2020 while sitting on the treadmill or while running on the treadmill or sitting on the cycle. So find something, or you do brainstorming while you're exercising. So you don't give up on it, do it. Find that time. There are certain things that make you happy, but you can give up on. Like say playing cricket with your buddies. It's difficult to do that every day. So do that on a weekend. Or playing pickleball with somebody, or doing something, some particular hobby that you want to indulge in. You do it on a weekend. And remember, weekend you have more time because you hopefully will be working less hours on that particular day. There are certain things which do not make you happy, but you can't give up on. Like for example, a family function. The opposite side family function is going on, you have to go. But one, either you can like it, do it on a weekend, or you delegate it. So you can ask your wife to go for it if it is her side of the family. If it is your side of the family, you go. Another thing we don't realize is we give ourselves too much importance. So suppose somebody invites us for a function, we think we have to go. We think the function will fall flat if we don't go. No. If the function is still going to happen, it's not like he's going to remember that you didn't come for his function and then he will beat you up the next day. So pick and choose. That would give you some amount of time to do the things that you want to do and at least make you happier and have a better work-life balance. And finally, there are certain things which do not make you happy, but which you can give up on. You delete them from your life. Social media. There's so much on social media. We're on so many WhatsApp groups. Many of the time we don't even look at those groups, but suddenly one message will pop up, then we'll look at it and then we go into the flow and we see a lot of other things. We waste a lot of time. You go to YouTube, you do some videos, look at some videos, that will lead you to another one, another one, another one. It will go on, and you're stuck in that loop. So you got to show discipline. You got to be strong, you got to be tough, and cut it short there. And I'm telling you, if you apply all these things, you will easily get that 1 hour that you require for exercise. And the whole point of this talk is to tell you how to find that 1 hour to exercise. And I don't have anything else more to say. Please apply this. You owe it to yourselves, you owe it to your families, you owe it to your patients. And I'm so glad all of you had the patience to sit through all this. And if you want me to do this talk in any other conference, I'm happy to do it. And please try and become the best version of yourself. There's a QR code there. If you want, you can scan it and then go into the website and see more details. Thank you all very, very much for being here. And I think it's time for lunch. And we've built up a nice appetite, I think. Can I just hand over to Reddy's, and let me just thank them for giving me this opportunity, Dr. Prabhat, and also Dr. Wali, Dr. Rajshekar Chakravarti is not around, and Dr. Sridhar. Thank you so much for giving me this opportunity. And have a great time. Have a wonderful Sunday. And go and watch Durandar today.
Thank you so much, Dr. Ravi Adil, sir, for that enlightening session. I'm sure most of the doctors are going to implement it in their daily life, making sure their work-life balance goes great. With that, I would like to invite Dr. Sridhar, sir, to kindly give the closing remarks for the session.
No more time, and special thanks to all of you, and special thanks to Ravi Andrews, especially covering non-nephrology topic and made them everybody interesting, skipping their lunch also. And initially I thought I should say apology for delaying the lunch, but now I felt happy after Ravi Andrews session. Right, thank you.
Thank you so much. Now we can break for lunch. Thank you so much, everyone. So it was an honor to have you all delegates today in this Regional Nephrology Summit, with an assurance that we'll have many more such kind of educational treat in the future. With your permission, I would like to close the meeting. Thank you so much.
PDF. It can instantaneously create 15 slides for you. It can instantaneously create a 5 minutes video with beautiful animations explaining that PDF. You just go home, type notebook LLM in search box, you'll understand how magical it is. For students, it's an excellent one. And more importantly, we are preparing for a talk, you just push some 3 to 4 PDFs into that. It will instantly create 100 flashcards or 100 quizzes to make you more preparative for the upcoming lecture and anything else. It's a beautiful tool for students or any person who want to learn further. And it has been created by a world-famous teacher who was almost equivalent to Nobel laureate in teaching. Google has hired that person, took his feedback, and converted his vision into a software. Notebook LLM is excellent, awesome.
Can I add another beautiful feature of Notebook LM? For people who are on the road for a long time, you upload a PDF and ask it to convert into an audio.
Podcast.
And it does such a beautiful job. It's like it doesn't get boring. It's very interactive, two people talking with each other. And then you are richer by one
Exactly.
article whilst you're driving.
Another thing, when IGA Nephropathy draft guidelines were issued by KDIGO, I just pasted into Notebook LLM. It just gave me a podcast. In 7 minutes, I could understand what are the differences between previous guidelines and the recent guidelines.
Anyway, I think the day is not far off when teachers will be replaced by AI. No more BC Roy Awards, it will be AI Awards. Anyway, I think I should conclude this by requesting Dr. Valli to conduct a tutorial for us and make us more knowledgeable in this AI field. Thank you all once again.
It can help us to identify the risk factors, sir, but definitely it cannot replace the clinical judgment. Thank you so much, sir. And I may request Dr. Krishnan, sir, if you can kindly hand over the memento to Dr. P.S. Valli, sir. Dr. Ravi Andrews, sir. Dr. Satnarayan, sir. I request Dr. M.V. Rao, sir, if you can kindly come onto the dais and hand over the memento to Dr. Krishnan, sir. It will be on anemia management in CKD patients. The session would be chaired by Dr. M.V. Rao, sir. And the speaker for the session would be Dr. Vamshidhar, sir. If I can request Dr. Vamshidhar, sir, if you can kindly come onto the dais to take his talk.
I can understand that many of you are angry that we are still continuing this topic, and many of us are hungry also. So I would like to keep the topic as crisp as possible and to cover the regions which are maybe partially less discussed in the previous panel session. I am Dr. Vamshidhar, and I recently shifted to Hyderabad from Lucknow after serving 3 years as faculty in SGPGI Lucknow. So I am very happy to interact with all the senior nephrologists here. So as we know that the anemia prevalence increases as the CKD stage progresses, and it is associated with many of the major cardiovascular adverse outcomes and poor quality of life. So there are multiple factors that causes anemia: iron deficiency, EPO deficiency, and poor responsiveness of the bone marrow, beside the inhibitors as well. And now the absolute iron deficiency in KDIGO 2026 is referred to as systemic iron deficiency, even though the values that they have taken, the cutoffs are same. Functional iron deficiency is referred to as iron-restricted erythropoiesis, and this change is to more accurately reflect the physiological state, because in systemic iron deficiency, we know that the iron reserves are low and we have to replace. In iron-restricted erythropoiesis, even though the iron reserves are there, treating with iron in this state also still helps improving the hemoglobin and decreases the requirement of erythropoietin. So regarding the diagnosis, it was already discussed. Evaluation was already discussed in CKD. The management predominantly revolves around the iron supplementation, B12 and folate supplementation, and ESA, either exogenous or endogenous through HIF-PHI. So what I would like to focus in my topic is that there is a major change in the guideline or recommendations from 2012 to 2026 from anti-iron to pro-iron. So what happened and why this pro-iron recommendation now? Why there is anti-ESA maybe now? Because I would like to quote this the story of ESA and iron, which is termed as one of the medical reversals. So it was when the recombinant human erythropoietin has come, it definitely has decreased the requirement of transfusions drastically, as we can see. And the initial concept was to correct the deficiency of ESA to have a better quality of life and decrease the requirement of transfusions and better quality of life, of course. And to whether it actually improves the survival was the question then. So in 1998, there was this normal hematocrit study which found that if we normalize the hematocrit and to a target of 42, whether it actually improves the quality of life. It compared against the low hematocrit group where the hematocrit target was 30. So they found that the study was prematurely terminated, by the way, because of the high adverse events and high deaths, both the cardiac and non-cardiac deaths that were happening. And the reason that was pointed out was because of the high IV iron use in the high hematocrit group. But we actually look at the reason. The problem is the high erythropoietin use in this patients with normal hematocrit group. So the use was more than 2.5 times higher when compared to low hematocrit group. But the conclusion was slightly different, and it was put on the iron. So it was later reanalyzed by Dr. Coyne et al. In 2012, nearly 14 years after the initial study has come. They found that the initial 95% confidence intervals were actually 99.9% confidence interval, and they found that the risk of cardiac composite outcome was significantly higher, 28% higher risk when compared to when compared to lower hematocrit group. And there was increased risk of death also. There were multiple, and because of the initial interpretation, there was a fear of iron toxicity, increased risk of infection, the fear of oxidative stress and erythrothrombosis. And KDIGO guidelines also did not set an upper limit, and it initially set a limit at which we have to start giving iron administration. At the same time, we have to target the same limit. So the ferritin floor has been mistaken as the ceiling, but we have to remember that ferritin in CKD state might not be a marker of iron reserve. It can be a marker of inflammation as well. So, and there were multiple studies in the same decade, TREAT, COIR, CREATE, which all have shown that the higher EPO use and higher hemoglobin target will actually increase the risk of mortality. So there were multiple studies following that to see whether the actual iron use is associated with increased mortality and whether it improves the hemoglobin. And this was FIND CKD trial in non-dialysis dependent population where targeting a ferritin of 400 to 600 actually improved the hemoglobin much better when compared to people who are targeted at a lower level. And there was this meta-analysis and systematic review which also found that the risk was, the IV iron use was not associated with any increased hospitalization or cardiovascular outcomes. And then there came this landmark study, pivotal study, where more than 2,100 patients were, ESRD patients were randomized into proactive group and reactive group. Proactive group has used 400 mg per month proactively, and they targeted a monthly, they have done a monthly labs, and they targeted a ferritin of more than 700 and transferrin saturation of more than 40. And in the reactive group, they have given IV iron only if ferritin is less than 200 and TSAT is less than 20%. They observed the patients they followed up for 2 years, and they found that the composite mortality outcome was significantly better, and more importantly, the ESA requirement was much better, and transfusion requirement was also much low when compared to the reactive group. So as we can see, this is the largest multi-centric RCT, non-industry sponsored trial, and they found that the ESA requirement is lesser, transfusion is lesser, and the overall cardiac outcome and the patient outcome was also better, and infection rates, more importantly, were similar. So this is where I think this is where the major shift in the strategy has happened in the management of anemia in CKD. The pro-ESA previously was now shifted to a pro-iron management. And as we can see in 2012 guidelines, we can see that the panel has clearly given that IV iron has to be given only if we are targeting to decrease the ESA dose or avoid the ESA use, and with a lower limits of upper limit, like TSAT was less than 30% and ferritin was less than 500. But in the newer guidelines, they recommend a proactive approach. The lower limit is still the same, but the upper limit, as we can see, is much higher, more than ferritin more than 700 and TSAT more than 40%. And even ISN guidelines also adopted the same. And even they tell that if the patient has refractory anemia and a high ESA requirement, TSAT is low, you can still give iron if the ferritin is more than 700. And if the patient is not anemic and the iron reserves are low, ferritin is less than 30 and TSAT less than 20%, even if the patient is not anemic, still iron has to be given because eventually iron deficiency will land up into anemia. So non-dialysis and peritoneal dialysis population, the lower limit is slightly is lower. Ferritin is less than 100 or TSAT less than 40%, or ferritin less than 300 and TSAT less than 25%. That's where you start, but the upper limit still remains the same. Coming to the various oral iron formulations, ferrous, ferric, and phosphate binding iron salts are available. Of course, the most commonly used among CKD population is liposomal iron if cost issue can be addressed. And IV iron formulations, out of the various formulation, iron sucrose, iron carboxymaltose, and iron isomaltoside are available. Coming to the iron sucrose, it has the, it was observed that the tissue deposition of iron sucrose, particularly in the hepatic deposition, is much higher. So iron ferric carboxymaltose is much easier to use, and the organ deposition is also much lesser. So iron, as far as ISN guidelines are 2025 are concerned, which was already discussed, they recommend the non-iron dextran formulations, and they advise to watch on the serum phosphate levels. And now that IV iron use is going to increase, there is a risk of more and more hypersensitivity reactions might have to be dealt with. So if the reactions are moderate to severe, then only the consideration of alternative iron preparation, or if the patient has severe reaction in the form of angioedema, then we might have to avoid IV iron use in future. Coming to the ESA 2026 guidelines, recommend a HB target concentration of less than 9 to 10 as a point where to start ESA, whereas ISN guidelines clearly tell for both non-dialysis and dialysis-dependent population, target of, less than 10 is a point where you start ISN, where you start ESA. So of course, the first generation, second generation, and third generation ESA were already discussed. What I would like to focus is which ESA is preferred. There was already discussion on the cost, as Dr. Srinivas sir has already pointed it rightly. The overall usage, even if we use a first generation EPO or a darbepoetin or pegylated EPO, the overall cost per month remains the same if we are using an equivalent dose of either of the compound. And this is clearly pointed out in ISN itself. And as far as which patient to use what, if we are using in a dialysis dependent population, EPO is preferred when compared to darbepoetin or sera. Close titration required, or if there is a rapid fluctuation in hemoglobin, of course we try to use EPO for a better titration and dose adjustment. And if a patient has a stable hemoglobin or non-dialysis dependent population, we try to use DPO or sera compared to erythropoietin. The HIF stabilizers, as we know, is the new landscape, and because of their discovery, the scientists Dr. Kalin, Dr. Radcliffe, and Dr. Semenza were awarded Nobel Prize in 2019 for their work. And beyond DPO, because it improves the transferrin receptors and decreases the hepcidin, it might be a potential solution to resolve the iron-restricted erythropoiesis, so far called as functional iron deficiency. So, practical considerations, KDIGO and ISN still recommend ESA as first line. And to consider HIF-PHI as an alternative, ISN recommends if patient chooses an oral agent, or if there is no access to maintain the cold chain, then to prefer HIF-PHI. Initiation dose is 100 mg per day, 100 mg alternate day or thrice, 3 times a week, administered on an empty stomach or 1 hour before food, and the dosage range is usually 25 to 150 mg thrice weekly. Maximum we can go up to 450 mg per week, and it has to be stopped if there is no response after 3 to 4 months. So we cannot directly prescribe, and of course we have to consider the potential complications that are bound to that might happen in over long term with HIF-PHI, because they are known to stimulate the vasculogenic and tumorogenic proteins, and hence it is contraindicated in active cancer, ADPKD, proliferative diabetic retinopathy, pulmonary artery hypertension, and pregnancy. So in our patients, so far where I was working, we have given HIF-PHI in a pretty good number of 526 patients. We had a follow-up data of around 436 patients. we observed for 2 years, we had observed cardiovascular event in 3 patients, and all the 3 had a hemoglobin of more than 12, which was unmonitored due to irregular follow-up. But fortunately, we didn't notice any occurrence of malignancy in them so far. So what has changed in the last decade in the management of anemia in CKD? There is a recognition that IV iron is no longer as harmful as once thought. Indeed, it may confer cardiac and survival benefits. Liberal amounts of IV iron is being used. Targets changed from TSAT of 30 to 40% and ferritin from less than 500 to more than 700. There is a change in balance between the ESA use and iron, less emphasis on ESAs and more towards the iron. If PHI should be used with caution, and of course, if the long-term data is good, it might be hopefully a future of anemia management in CKD. I would like to thank everyone for your patient listening.
Thank you, Dr. Vamshidhar sir. I may request Dr. Emirao sir if you can kindly come onto the dais. The panelist for this specific talk would be Dr. Rega Paladugu ma'am and Dr. Kiran Kumar sir. Requesting you to kindly come onto the dais. Sir, if you can.
It's an impending launch of a new molecule in anemia management by Dr. Reddy's. From what the extensive discussion we have had, probably one of the PHIs. Apart from that, I would like to limit the discussion to just 1 or 2 questions. This one is first addressed to Dr. Rekha. Do you see any benefits of long-acting erythropoiesis stimulating agents over the short-acting ones in dialysis patients specifically, not in the pre-dialysis stage?
In dialysis, basically, I would use in 2 settings, sir, where the patient compliance is a big issue. If they want to use only at home, sometimes they don't want to use some of the molecules in the center because they're expensive in the hospital. So then I continue the like pre-dialysis to dialysis, I continue those molecules. So which will be once a week or maybe twice a month like that. And some of them don't like getting more injections because I prefer subcutaneous injections over IV. So even in dialysis patients, I advocate more of sub-Q. So if they are more inclined for sub-Q, then I generally continue the darbepoetin, which can be much more beneficial. And as already mentioned by previous speakers also, when there is a lot of fluctuation, I go for erythropoietin. But if there is stable CKD, stable hemoglobin, then I generally prefer the long-acting darbepoetin.
Do you still, in any of your patients, you use the longest form of acting ESA, Mircera?
No, sir. I
Probably
generally use...
one should remember probably the use of Mircera has gone down drastically compared to darbepoetin for inexplicable reasons.
Overall, I think it's because of the cost. When you say that
Cost
the one injection is that expensive, that's
Maybe
what I heard from patients.
Yeah, okay. The second question is addressed to Dr. Kiran. What are the conditions where you absolutely want to avoid using PHIs, and what are the other conditions where you are likely to use PHIs with caution?
Yeah, I think this question has been already answered. Dr. Shrikant in the previous session also had answered this question. Basically, HIF PHD, that is prolyl hydroxylases, are important not only in erythropoiesis, but they are involved in other processes like angiogenesis, cell migration, then glucose metabolism, energy metabolism. So that's the reason why there are a lot of concerns regarding cardiac, that is thrombotic episodes, cardiac failure, because they can cause cardiac hypertrophy, then pulmonary hypertension, then worsening of hypertension in dialysis patients. So, and also in patients with dialysis who are more prone for vascular calcification. So that was about cardiovascular. Second thing is cancer patients. So cancer growth is noted in some of the trials. So these patients also we have to use these agents with caution. The third thing is PKD patients where cyst growth is also seen in certain trials. Another thing is diabetic retinopathy or proliferative retinopathy, where these agents have to be used with caution. Apart from this, some of these studies have also shown that these agents can cause hyperkalemia as well. So again, in dialysis patients, we have to use with caution. And in patients with liver disease also, HAF, PHD inhibitors have to be used with caution.
He has covered almost all the aspects. The last question is addressed to Dr. Vamshi regarding usage of extreme high dose of erythropoietin, 10,000 units and other higher doses. They are not generally clinically used in our dialysis patients. We try to give at intermittent durations the lesser doses. Why is it so? And do you reserve these particular extreme high doses for any particular set of patients in your maintenance dialysis patients?
Dose of more than 20,000 units per session, single administration, that was found to have a higher cardiovascular events. Less than that, the studies have shown that even if the dose is given at once or split into 3 sessions or 2 sessions, the outcomes are same. So I would reserve this particular type of administration to people who have a stable hemoglobin or a non-dialysis population who come to us or who prefer a less frequent administration, sir. So if it is a dialysis dependent population, of course, a split approach or more frequent approach is equally beneficial, and it's not of, it doesn't make much difference because they are anyway going to come to us, and we are going to give EPO.
Sir, vascular access thrombosis has been a common concern, and it has been shown long-term acting ESS has lesser incidence of vascular access thrombosis compared to short-acting. So your take on that?
As far as DPO versus EPO are concerned, the efficacy-wise, both have similar efficacy, and the complications also, there is no much difference as far as EPO versus DPO are concerned. So it depends upon the patient and the physician's preference that the ESA choice has to be taken.
In some of the rural units, we have seen some prescriptions or patients are receiving extreme high dose with once a week. So probably that practice has to be kept in mind when they come to us.
Yes, sir.
Whether that's not a good sign. I think
we'll end.
Yeah. I don't think there are any questions from the audience. The audience is exhausted, obviously.
No issue. So thank you so much, Dr. Vamshidhar sir, Enviraj sir, Rekha ma'am and Kiran Kumar sir. I request Dr. Enviraj sir, if you can kindly hand over the memento to Dr. Vamshidhar sir. Dr. Rekha ma'am, it's a non-dialysis patient, so would like to hear from you on those aspects.
I have, again, when it comes to non-dialysis patients, making them take an injection is a challenge. I think HIF-PHI inhibitors have a strong role in managing anemia in non-dialysis patients.
Regarding choosing of which erythropoietin,
Yes,
so based on the affordability of the patient and the state policies will decide. Like we have a large dialysis program, we use thrice a week erythropoietin, which is approved. So actually, as Srikanth was initially mentioning, compliance. Patient will remember that each dialysis I should take 1 injection. That's the policy. Otherwise, we have to fix them to once a week you have to take, or once in 2 weeks we have to take. If they miss out that date, that's a problem. Or once a month we have to take. It depends upon the compliance issues also will be there. If at all I say that actually after dialysis you take erythropoietin, that's it, like thrice a week. That's easier. Yeah, I think sir wants to make a comment on that. Yeah.
Superiority of one molecule over the other. So if you have no concrete data to establish the superiority of these long-acting erythropoietins, we're talking about convenience in one aspect, but
You're right, sir. The cost of these the short-acting erythropoietins is very, now in NIMS we had a rate contract for 80 rupees actually. 80 rupees is 4,000 rupees injection.
Exactly. I was just discussing with our friends here.
Yeah.
Sir, would like to...
There was a time when erythropoietin was being marketed and for 1,500 rupees 15 years back. And erythropoietin now is available for, as you said, in net
80.
contract is available, but even for commercial retail use, about 200 rupees.
We got 80 rupees,
yeah.
so like 3 times a week
Even
also.
across the counter, our patients are able to procure it at 200 rupees.
Yes, sir.
So this is much better than what, long acting which we are talking about, and then.
Yes, sir.
Yes, sir.
Sir, I cater to a couple of centers of Arogyasri dialysis centers where they get their dialysis done there and the outpatient follow-up is with me. Then I also have run my own unit. There is not, of late there is not much difference, even if you go by what sir has said. A 200 rupees erythropoietin into 3, 600 rupees. The darbepoietin, some molecules are available at 700, 750 rupees. And then once in 2 weeks or sometimes once in a month, schedules have been found to make the compliance really better. And especially these 2 dialysis centers where I do visit, the cold chain is always a big question. And even if they are giving it or also is a big question. So for those patients whom I visit and see, and I have seen this darbepoietin working reasonably well at a reasonable cost. It's got its own issues, but definitely this once in 2 weeks, I have put it as 1st and 15th to make it easier for a local language speaking population with no, this thing. 1st and 15th till the hemoglobin is 12 and the Lakshman Rekha to be 12, stop it immediately and come back to us. But I don't know about Sira, but the darbepoietin and the thrice per week erythropoietin, it has come almost to a comparable level, sir, as of now.
So multiple doses of erythropoietin, are there any concerns of hemoglobin variability that you see? Because data has shown that
As Srikanth was mentioning, if at all you achieve that number, maintaining will be better with long acting. But if at all you achieve that number, let us say 12, then you stop it. Then better I will like to start the short acting if at all it is going down to improve that and then maintain that's better. Because we cannot give a long acting with 12. How many months we have to wait till it goes down and we have to give it. That's a problem. So it's a mix of the things that we have to use. Both long acting and short acting have their own role. So based on the clinical discretion and patient variability of the hemoglobins, that can be decided. So regarding the dose, intravenous or subcut, already Srikanth has mentioned, better to give subcut rather than IV. And other thing is regarding use of PHFIs also he has mentioned. So how in clinical scenario, in what clinical scenario are you using PHFIs?
Mainly, I use HF inhibitors in patients with like compliance issues, mainly rural population who are not very inclined to take injectable drugs. That is the main thing. And when there are logistic issues with regard to cold chain management. So these are the 2 patient groups which like I prefer to use HF inhibitors. And one more thing is if there is uncontrolled hypertension in spite of using multiple drugs, I tend to prefer HF inhibitors rather than erythropoietin.
I have very limited experience on these drugs because the population I treat is extremely averse to using these drugs. So yeah, I am still a novice in this.
So Srikanth, what's your experience?
So 1 or 2 things which have been clearly stated is to avoid in patients with polycystic kidney disease, malignancies, diabetic retinopathy. So these are the 3 things because it's very easy to overlay these 3 problems in an OPD. You have a patient of CKD and his hemoglobin is low, the tendency if you're using the HF-PHI inhibitors, you can by mistake also prescribe for these patients. So these are the 3 sets of patients for whom you have to be extremely careful.
Actually, we also use, but in dialysis and non-dialysis we used, but we mainly preferably using in erythropoietin resistance rather than routinely we are not using them. Though we had one student has done a trial on using this the oral PHFI in dialysis patient and found the hemoglobin was improving. But though it is rate contract is there, still the resistance is there in using the medication on a routine basis. So though it is available in the government sector now, PHF is available, darbepoetin is available, and erythropoietin, all three are approved. But utility depends on the clinical scenario, then it's a clinician discretion which is mattering.
One thing KDIGO states clearly is not to combine that. We have been doing in for not patient who has resistance.
Yeah, not routinely we are combining.
KDIGO says not to.
Yeah, not to combine, but recently also international forums also we discussed. Only selected patients, they are not responding. In those scenarios we are using, they are actually improving the, making the more inflammation come down and utility of iron will be more. So in those scenarios, rarely we are using combination of these drugs, and we observed that actually the hemoglobin is improving in those scenarios.
Actually, there are some reports of its use in pure red cell aplasia, which are coming up, but like, this is too early to.
So ultimately, the practice, clinical practice, where as sir was telling 15 years back, using EPO irons were very, like I started as residents when Vinofer was imported, and we started using Vinofer was there, iron sucrose. It was not very much available. We used to give only iron dextran at that time. But now a lot of improvements are there, a lot of iron preparations are coming, and we are using routinely. And also we are using erythropoietin routinely to the patients. Their hemoglobins, like our NIMS also, more than 1,000 patients on dialysis, there only 10% of the population are having anemia by definition. Everybody is getting erythropoietin. Only peripheral centers which we are trying to have a hub and spoke model, where a supply chain issue is there, where hemoglobins are lesser. So what quality of life change that you are perceiving different in these patients? They are using routinely the erythropoietins and the irons as a routine versus before, where the issue of affordability and the supply was there. What's your opinion?
Yeah. This hub and spoke model and government supporting the dialysis program in the state started when I was a student, something at that time. Like everybody, we too were skeptical what the long-term impact. But I can vouch, I work on two peripheral areas which connect to two districts. All along from Hyderabad to that district, I see definite improving in the longevity of life and quality of life. There may be n number of glitches in the model of this free dialysis. There have been many people who questioned it too, but it's been clear that it has made a difference to the quality of life, duration of life, and the economic stability of that family. I lose every month, I lose a half dozen patients to this Arogyasri model, but that doesn't matter. But I see that they are surviving. And erythropoietin, if it is given regularly in some center, they do well. If they are not given, they come back anyway to us for the guidance. At least iron is being given, that's clear. Erythropoietin, I'm not sure if it is being really given in all centers. Very they are doing well. And even at that hub, in this hub and spoke model, now I see a survival for more than 10 years. I have seen patients who have on this free dialysis thrice per week. The patient is intelligent enough to come for a monthly review. He says, I have saved money there, I will better spend here, get my test done, get my review done. 10, 12, 13 years free dialysis. People are doing well. They have other problems. So yeah, I have seen a drastic change in this model. There is no doubt. That's why I am associated with a medical college also to develop a dialysis center in a medical college at a periphery setup of late, because I have seen the benefits, no doubt about that.
Thank you, and we close the session. Any more comments from the audience? Or Saha sir is,
I think we can move into
this. I think we are already closing. So before closing, customary to ask you whether you want any comment.
No,
so, okay. Then I think we already understood that when to use iron, what type of iron to be used, and erythropoietins also long-acting, short-acting, and I thank all the panelists who
maybe we can have more discussion on that
from
in
the
next
real-world
talk,
experience.
Sir.
Thank you very much.
Sure, sir. I request Dr. Gangadhar sir, if you can kindly hand over token of memento for Dr. Shrikant ji sir. Thank you so much, Dr. Krishnan sir. Now you move to the last session where we have Dr. Ravi Abraham sir, Ravi Andrews sir, who would be discussing the work-life balance in his own unique way. And he will be accompanied by Dr. Shravan Kumar Jogu sir.
We are doctors, we have to be a little patient though. Because whenever there is music involved in any program, it takes at least 30 minutes for the musicians to tune up and get ready. I just want 2 or 3 minutes.
Have been waiting eagerly to discuss on role of AI on your as your second brain and its role in nephrology practice. For this, the session would be chaired by Dr. Krishnan sir, and the session would be taken by Dr. P.S. Valli sir. I request Dr. P.S. Valli sir if you can kindly come onto the dais.
Afraid for two reasons. First reason being I am talking in front of full panel of my all teachers who changed and defined my life. Second thing is I am hungry. So I will try to make it a fast presentation, madam. So basically, I will start with a narration. Recently, I happened to be at a scientific session wherein cardiologists were dominating. The topic assigned to me was approach to a case of resistant hypertension in diabetic kidney disease. I gave the established algorithm. During the panel discussion, one of the cardiologists asked me, why are you not talking much about beta blockers? You are talking about calcium channel blockers, diuretics, and ARBs. Why not about beta blockers? I replied, sir, beta blockers after a point of time, they cause hyperkalemia. This made the cardiologist furious. Not only he asked his 2 other colleague cardiologists to argue with me. I was really battered. As you all agree, like all of you, I am a person who believes that the more arguments you win, the lesser friends you have. So I voluntarily thought of not arguing and accept my defeat. Then they were discussing about, the panel was discussing about something else. Then I gave this prompt to Perplexity, the exact prompt I gave to Perplexity. You play the role of nephrologist with special expertise in resistant hypertension CKD. Answer crisply with most credible established scientific logic regarding this topic. Can beta blockers cause hyperkalemia? It gave me this beautiful response. You know, the answer was within 15 seconds before I could open my mouth for arguing. It clearly told that beta blockers can contribute to hyperkalemia, can cause hyperkalemia. They are going to be more problematic in diabetic kidney disease patients because already they are on the verge of hyperkalemia. Well, I did not talk anything. I just told that, okay, sir, beta blockers are darlings not only for you, for me also, we'll accept. I came home, I searched it in all the books. Fihali, Up to Date, and Harrison all clearly mentioned that beta blockers do produce hyperkalemia. On the day I repented that you are all not there in the hall because at least you all people would have defended a nephrologist because you all know that hyperkalemia is much contributed by beta blockers. Therefore, what I mean to say is the topic of the title is AI is not a brain, but a second brain. When calculators were invented, there was huge protest in England because England was a conservative country. People said that this is going to kill human brain, people are going to become much more lazy. But can you imagine a world without calculator? It made our lives much easier. This is the future of AI. AI is not going to replace, but AI is going to replace a person who don't know how to use AI like a slave. So the very purpose of this presentation is to tell us few tips which I learned. So what is GPT? We all use ChatGPT, but what does GPT stands for? GPT is nothing but G stands for generative, P for pre-trained, T for transformer. ChatGPT is not a genius. It don't know anything. It don't know any logic. What it knows is how to structure a sentence. It structures a sentence by debating with itself for millions of time in a second, in a fraction of a second. Because it has been trained with enormous amount of data. So it has just eaten away huge amount of data. It knows how to fill a sentence. It fills a sentence in such a faster speed that at lightning speed, you cannot imagine, you cannot define how speed it is. Therefore, it is basically a writer. It knows how to fill a sentence. That's the reason it's a confabulator. It's like a drunken kid. It just knows how to confabulate. It knows how to hallucinate. But basically, it will hallucinate in a most logical, reasonable way because it knows how the data was given to it, how to process it. So G stands for generative. That means it will generate the test. Second one is pre-trained. Probably it underwent such rigorous training which probably no other platform on earth has been trained for. And then transformer. Transformer means by using its trained data, it has a neural connection like our brain connections, wherein each compartment will argue with another compartment and come out with the most probable answer. Then how does it answers? First, it requires a prompt. Prompt is a soul. Once you give a prompt, it breaks down this prompt into some 1,000 small fragments which are known as tokens. That's the reason every AI network talks about tokens. Token is nothing but a small chunk of text. Then it will predict what is the next text, that is token, and then generates a response. Therefore, the first and foremost answer is how to give a prompt. Therefore, for example, if you ask it how to bake a cake, it never baked a cake, but it knows how people talk about baking the cake, and it gives the most probable response, which we presume the right answer. So ChatGPT is not genius, it's only a text maker, but a best text maker. The second tip is to use ChatGPT, to use Perplexity, to use Gemini. The soul is the prompt what we give. If at all you are not having patience to give a prompt, don't expect any good response from any of the ChatGPTs. Then what is a prompt? Remember this acronym, RCTC. That means R for role. Whenever you ask something, first assign a role. For example, we ask an academic question. You tell that you are a world-famous nephrologist with special expertise in transplant. You are a world-famous nephrologist with special expertise in anemia. You are a world-famous nephrologist with special expertise in conducting RCTs. Then provide context. Context means, I am having this much problem. I am looking for this particular answers. And then give the task, what it need to be done, and then say what not to do. The simple thing is what I do is, you give any scientific prompt, but end the sentence with one simple phrase. The phrase is, don't hallucinate. Once you add this sentence, it will understand how to behave like an intelligent person. Therefore, you should give a role, you should have a context, you should have a task, and then constraints. For example, act like a senior academic nephrologist. Context being, I am writing a discharge summary for a 40-year-old transplant recipient. And third one being task. Summarize, for example, any other prompt, summarize the latest KDIGO guidelines, and then constraints, what need to be done, and how should be the output. Whether output should be in bulleted points or in a plain text. Trust me, the Gemini can directly give you even PDFs also. The Gemini AI can create the beautiful slides what you are seeing. Every slide has been made with AI. I just fine-tuned it. But the question is, you should know how to train it, Therefore, good prompt is everything. For example, one of the example prompt is, summarize the key findings regarding the use of SGLT inhibitors in IgA nephropathy. Focus specifically on results from the recent trials regarding the proteinuria reduction. Present the data in a comparison table. That means you are giving a role, you are giving a context, you are giving a specific task, and also you are telling how should be the format. There are some basic tips regarding prompting. So as a clinician who always searches for the best possible scientific answers, the first one is you should assign it a role, specialist consultation, and then you should make it very specific. Already, if at all you are having an example of a document, you upload the document. Then you ask ChatGPT to replicate it in his style. That means you yourself will feed a data, then ChatGPT will try to understand your style. And third one is clinical reasoning. For example, if at all you want to have any answer, how to treat CMV infection transplantation. In one among this prompt, you should have a compartment stating that, let us think step by step. Once you use the word, let us think step by step, ChatGPT trains itself to think like a nephrologist who is having expertise in that particular field. Therefore, this particular magical phrase, let's think step by step, will allow ChatGPT to give the most logical response. And then exclusion criteria. For example, if you just give a vague trial, what is the treatment of CMV in transplant? It will start talking about 1980s to till date. Therefore, to have a more refined data, just ask it. Focus on the current international national guidelines. Adding this single sentence will drive ChatGPT to give a more customized and more practice-oriented answer. Therefore, these are the most important rules what I have learned. And most important tip is, not every AI platform is the same. You all know, these are the three most important AI platforms, ChatGPT, Perplexity, and Google Gemini. ChatGPT is a parrot. It's a wonderful parrot. You ask it, it will write. You ask anything, it will write. Even it can help us in even doing homework for kids also. It's a wonderful creative writer. Regarding Perplexity, it is the most authentic, dependable scientific writer because whatever it writes, it gives a reference. Not like a bogus references like ChatGPT, but clickable, true references. Therefore, from academic perspective, probably there is no substitute for Perplexity. Regarding Google Gemini, it is the best possible GPT till date, till now. Previously, we used to talk about ChatGPT, but Google Gemini is far, far ahead of ChatGPT. It can do anything. You just try anything with it. You just give any document. You just give the entire textbook of nephrology. It can analyze still. It is having such a reserve capacity. You are about to give a lecture. You want to watch a KDIGO guidelines video, which is for 1.5 hours, because each KDIGO conference video will last for almost 2 hours. You just click the link, copy the link, paste it into Gemini, and then ask, please summarize this video in 80-20 format. The word 80-20 format indicates that give me 20% of the sessions, which is going to serve 80% of my role as a speaker. Once you use this word 80-20 format, it is just going to extract the juice from it and going to present in bullet points. The entire 2 hours video will be summarized in a span of 4 minutes by Gemini. Such a powerful platform it is. Therefore, just imagination is the sky. It all tests your creativity. Regarding ChatGPT, it's a wonderful writing component. You can talk with it by having any conversation, but only issue is it never gives proper citations. Probably, it has been designed in such a way, whatever citations it gives, they're all bogus citations. Therefore, use ChatGPT only as a writer, never for any academic writing. Whereas Perplexity is a wonderful platform. That's the reason it has been in the news. That's the reason Perplexity had dared to buy even Chrome browser also. It can accelerate literature reviews. There is one of the beautiful property with Perplexity, research mode or deep thinker mode. Once you give any idea or any topic, for example, anemia in CKD, the recent guidelines, and thinking mode, it will prepare literature review within a span of 7 minutes. It's a class apart literature review. But most important thing is you cannot chat with it because it has no memory. It will give first one answer. If you start asking about the same context again, it will forget. Therefore, it can generate instantaneous literature answers which are very much replicable and authentic. The citations what it gives are perfectly clickable, foolproofly clickable. Every citation what it gives, I challenge, you just click it, it will open a true page. Whereas Gemini AI, it is a horse. It is a workhorse. It can do everything. It can create beautiful images. All these images have been created only with Google Gemini. We should know how to prompt. So whenever you ask it to create a slide, you just ask it, create a horizontal slide with academic colors. If you don't use this word horizontal and academic colors, it will give some vague answers. Therefore, whenever you want to prepare a slide, you give academic colors, horizontal slide, decent enough to present in academic platform. Then, fifth tip being how to demand the best authentic scientific output from Perplexity. There is a way. This applies to Perplexity. Whenever you're asking some question, you're demanding some answer from Perplexity, use these 5 components. Activate the academic mode. In the Perplexity, there is an option wherein you can just choose academic mode. Once you choose academic mode, it is just going to have the PubMed mode. That means it is going to just review the PubMed mode. It is not going to look at the blocks. Therefore, activate the academic focus mode. Second one is, you just clear-cutly say whether you want to have data from 2000 or 2010 or 2020 or the most recent 4 years. You can also say what references you want to have. Whether you want to have only from NEJM, you want from Lancet, or you want to have all top-read medical journals. And then the most important thing is, if at all you have stronger statistics, you can even demand for statistical evidence also. Because whenever you ask it, include hazard ratios, 95% confidence intervals, then it is going to decrease the hallucination power of this Perplexity. And then ultimately, you just ask it, give the output in the form of a table. Then it is going to have beautiful comparisons of various studies. Therefore, by remembering all these 5, you can best use Perplexity and you can drive it to be your academic assistant. AI is hallucination, hallucination is AI. AI can never escape from this property. Then how to force AI from not hallucinating? This is a framework. Whenever you give a question, especially academic question, you want to have authentic short answer, you follow these 4 components. Ask for a conclusion. You give a prompt and then say, please give a crisp conclusion, and also give 3 supporting reasons, and have 2 counterpart arguments, and then give final recommendation. My best question is, the model, what I follow is, I have almost a prompt library of around 800 prompts. So whenever I want to have particular thing, I will just go, copy, and then paste. I will just have minor adjustments. So whenever I am searching for some academic reason or academic answer, I just make sure that I will type, ask for conclusion, demand for 3 supporting reasons, request for 2 counterpoint argument, and then ask for a final recommendation. Once we are patient enough to incorporate all these things, no textbook can give such a credible answers like what Perplexity is going to give. Still, the juice is still there. One ultimate tip to get the best focus reply is, after giving the prompt, just type, before start answering, ask me 3 questions that will improve the accuracy. I challenge, this is the best tip. You give any prompt. Once you give the prompt, don't click go ahead. Just type, before answering, ask me 3 questions that would improve the accuracy. This will make ChatGPT or Perplexity or Gemini to ask you 3 questions. That means it is going to ask, how much amount of duration data you want? Are you going to address for who are your target audience? And which journals I need to focus upon? Once you give these answers, you are going to narrow it down, and once again going to reduce the hallucinations. And the 8th tip being, how to train AI to help you widen the opt differential diagnosis. Because the ultimate purpose of living as a clinician is to widen our differential diagnosis our lifelong. That makes us a clinician. Still, ChatGPT or AI can help us. So first of all, identify a complex case, and then give a specific prompt. For this example, for a person having hyponatremia, regarding workup of hyponatremia, I gave a prompt. I have a patient with serum sodium of 125, urine sodium of 10, urine osmolality of 600. Patient is euvolemic. List top 3 differential diagnoses and suggest the next best diagnostic step. Explain your reasoning. Once you use the word explain your reasoning, then once again it is going to shorten the hallucinations, and it is going to come out with the most practical way. Thereby, we are going to increase the safety of the answer, the practicality of the answer, the adaptability of the answer. Still, the 9th tip being, don't settle. Still, the juice is there. Make AI to push further and ask for more juice. The tip is, once it has given an answer, ChatGPT expects us to give a reply. Most of us, what we do is, we'll just read the reply, we don't give our feedback. It is your duty to train the ChatGPT. Because ChatGPT has been based on this feedback loop. Therefore, once ChatGPT gives a reply, if at all you are not happy, please say down thumb. If at all you are happy, click upward thumb. This is the most important part. This is the thing what we don't do. If we don't give, then how can the AI can understand which prompt it is giving is good, which prompt is bad, and which reply is good, which reply is bad. Therefore, make an effort to give the feedback. And more importantly, once it gives an answer, once again type it. What did you miss? Add 3 refinements and highlight the changes. Once you give this reply, it is going to come out with more beautiful refinements. That's how we can make ChatGPT better, we can make Perplexity better, we can make Gemini better, and it can make us more important counterpart. That's the most important crucial step in making AI our second brain. Of course, this is the most important asked question. Is there any AI tool that can make research paper write better? Yes, there is one super tool which known as Genie AI. If you go into for that, if you just ask, if I want to write a case report on tacrolimus toxicity in a kid, if you just give this prompt, it is going to structure the same introduction, the case details, everything. And it is going to avoid the writer's block. That means, once you write a post-transplant patient of 16-year-old who was on 3 drug immunosuppression, once you type this sentence, it starts filling up everything. It's a AI sentence. We should not copy and paste it. But by using this, it is going to mitigate the writer's block, how to write further. Once it gives the entire context, we can once again rewrite the sentences in an easier way so that AI detectors are not going to pinpoint. Therefore, it's a Genie AI which is going to help us a lot in overcoming the writer's block, it is not going to replace a rating. If you just send the same thing for publication, it is going to be rejected because AI detectors are going to point out that this is an AI content. But by using this, we can just overcome the writer's block and make sure that the flow is obviously going forward. And most important, everyone who uses ChatGPT or Perplexity, they all have one hardship. The hardship is lack of uniformity. Then how to increase the uniformity? For those who are using ChatGPT can very well understand that there is a beautiful option known as projects. Once we try to club all the needed responses into projects, then ChatGPT is going to understand that this particular project belongs to only academic perspective. This particular project belongs to only financial perspective. This particular project is only for personal projects. Therefore, try to use the project thread under ChatGPT. And the last and most important tip being to understand that ChatGPT is not God, but it's the greatest hallucinator. Therefore, you enact that you are believing ChatGPT, but don't completely believe ChatGPT. There was recently a famous newspaper in Pakistan, English newspaper in Pakistan, has written an article on the upcoming changes in the automobile industry. It is supposed to be a beautiful paper, but unfortunately the editor forgot to remove the last sentences, because the last sentence was, this is a prototype, do you want to come out with another lens? That means that's what happens, because we try to just cut, copy and paste, but we don't remove the last two sentences, because last two sentences are going to be clear-cut navigators that we used. After that, that particular newspaper share value has crashed and it became an international joke. So always be careful with AI. It is going to create confabulations. You should be intelligent enough to mitigate that. And more importantly, already in Western countries, there are strong enforcement regarding sharing patient data. The most important thing is once a patient sends us, because this happens with relatives send us this much amount of reports on WhatsApp. So what we do, we just try to give the same reports to ChatGPT, ask us to analyze for abnormalities. It will go into analyze within a span of 30 seconds. But only issue is, after a few days, even in India also, there might be a rule where you should not share patient data with ChatGPT or anyone. Therefore, try to train ourselves so that we are not going to feed more amount of patient privacy details into ChatGPT. So thank you so much for the patient listening.
Thank you so much, P.S. Wali, sir. If I may request Dr. Krishnan, sir, to kindly come out of the dais. He'll be joined by Dr. Ravi Andrew, sir, and Dr. Satyanarayan ji, sir, for the panel discussion. One chair, please.
Hello everyone. My name is Dr. I want to help you evolve and shape up into the best possible Homo sapien. As Dr. Homo sapien, may I suggest something to you? Do not try to be like someone else, like your heroes or your idols. That is not possible. So strive instead to become the best possible version of yourself. But am I the right person to help you on this journey of evolution? Yes, I am. Because I have done it myself. And today, I would love to share this formula with you. Thank you for listening.
I request Dr. Swarnalata ma'am if you can kindly come onto the dais and hand over the. Thank you so much, everyone. We'll move to the next. Dr. Naveen Kumar, sir. Dr. Srinivas now, sir. I request Dr. Ratanja, sir, if you can kindly come onto the dais and hand over the moment to Dr. Gangadhar, sir.
As was expected from Dr. Valli, well, we have to accept AI. AI is there everywhere, every aspect of life. So clinical practice is no exception. And of course, sifting through the enormous data that we have in the hospitals, whether case reports or biochemical or X-ray pictures and scans, sifting through the entire this thing of gamut of data, one has to learn AI and make the best use of it. Dr. Valli Seta, I wanted to ask you one thing. Now that you have been into AI so well, so deep, what has been your experience? How much have you utilized this for your day-to-day clinical practice?
Sir, basically I'm not using it like a clinical tool, but really there are some examples where AI has helped me a lot, because I was having a lot of trouble in drafting discharge summaries. I was not expecting a good quality discharge summaries from our juniors. Then I just made them to use AI, and now they are giving wonderful discharge summaries. Because I just made them 7-point formula, they are going to enter the 7 probable this one, and AI is going to convert. There will be confabulation, but still. And second thing is regarding updating ourselves. Previously we used to spend a lot of time. Now, if at all we want to study a paper, just upload it to ChatGPT, ask it to explain in 80-20 format. It is going to give only 6 points, 6 most important points. So it is going to make us more wiser, sir. But only issue is we should have that ability to remove the confabulations.
Ravi, I wanted to ask you one. So with the advent of so many gadgets, we know our children or everybody around, the art of reading or writing has gone. So most everything is through smartphone. Now with AI, what do you think is going to be our juniors' clinical practice, clinical acumen? How good clinicians are we going to produce?
So now I think one thing that I want to establish is the American Medical Association has said AI, the full form shouldn't be artificial intelligence, because that has negative connotations to it. It means something which is not natural, and there's always fear that AI will replace the doctor. So American Medical Association suggests that we call it augmented intelligence, not artificial intelligence, because AI is only going to help the doctor. It's not going to replace. So I think that's one point that we need to hang on to when we talk about our younger people using all smartphones, trying to get information. They need to understand that it's only going to help them, it's not going to replace them. And how do they apply it clinically? I will answer this in two methods. One is, how do you apply AI generally in clinical practice, in healthcare? There's a nice mnemonic that I've got, which the juniors would like to hear. It's called RAPID, R-A-P-I-D-D. So R stands for remote monitoring, so you can use AI to remotely monitor your patients. A stands for analysis of data, so data can be, a lot of data is available, you can analyze it. P stands for precision medication, so you can precisely give medications based on the genetics, the age, the sex, the geographical distribution. I is for image analysis. AI is used to analyze images much better. Even it could replace a histopathologist according to some places, some papers. And D is for diagnosis. AI helps in diagnosis. And the second D is for drug development and discovery. So new drugs can be discovered. So this is generally how AI is useful in clinical medicine, which we need to hand over to the youngsters. Specifically in nephrology, AI is used in every aspect of nephrology. If you look at AKI, AI is used to identify patients who are going to develop AKI. There was a study done on cardiovascular surgeries, and with 90% accuracy, AI could say that this particular patient is going to require dialysis. In CKD patients, it's used for prediction models. We all know about the IgA nephropathy prediction and can tell us onset of end stage in IgA nephropathy, onset of end stage in ADPKD by looking at the renal volumes by studying MR images. AI is used in dialysis patients because it helps reduce the dose of erythropoietin to maintain a higher hemoglobin. A study was done by Barbieri, and it's a landmark study really. We are also using a kind of model to try and figure out people who, to try to dose erythropoietin to maintain a proper hemoglobin in our patients in Apollo Hospital at present. And in biopsies, AI has shown itself to be slightly better than histopathologists to at least quantify IFTA, and in transplant patients to allocate patients donor organs more better and to predict graft survival better. So these are all the things that we can tell our youngsters. Luckily, we're not in Australia where it's all banned. We're using Instagram and other things, and other social media is banned for youngsters. And how young are you going to really start them off with? Our people are old enough to understand the realities of AI. And just to end this, this is in the realms of science fiction. In the future, what could we see with AI in nephrology? I could envisage a patient who has a transplant, who has an implantable device, and that would feed data, and that would tell us if the creatinine has gone up. Then he would get a red flag, the nephrologist would get a red flag. This person would come to the hospital, an ultrasound is ordered, ultrasound done, images seen by AI, and ultrasound normal. So biopsy is done by the nephrologist, images seen by AI, and they say rejection. Treatment is monitored and is given according to the patient. It's precision medicine is given, and then follow-up is done. So this might be 10 to 15 years in the future, but that is probably going to come. And this is the realms of science fiction. But if you noticed, I've removed everybody, every other doctor from here except for the nephrologist.
That's true. That is the fear. Like for instance, now over the years we know now we practice medicine more to save ourselves than to save the patient. You have to be legally correct, you have to be ethically correct. Like that, I think now henceforth our training will be such that we should be correct AI-wise, because somebody else is going to counter-check with AI to see if your diagnosis is correct, if your interpretation is correct, which is rather unfortunate because ultimately it's going to be a fight between humans and the technology probably. So Dr. Satyanarayana, what do you feel is the future, next say a decade from now?
I think I'm audible. Yes. So I feel that we should embrace the AI, incorporate into the regular practice, but not over-rely on it. So my experience with AI, I have a close cousin who was initially working for OpenAI. So when I asked him, initially when ChatGPT was launching, now he was poached by Gemini. So I asked him, what is this ChatGPT and all? Even when ChatGPT was not launched, he was into the OpenAI, he's a data scientist there. So I asked him, what are you developing, what is this and all? He said, we develop data-based learnings, so don't over-rely on these things. what we give is called black box course. So what AI gives you is called black box course. What is a black box course? You know the input, you know the output, but what's happening inside, you don't know. For example, you have given a patient input, the AI says that the risk of AK is 92%, but why is 92%? Nobody knows. So you should question, AI should be accountable, that is what he said. So don't blindly rely on AI, keep your mind open, and data can be wrong, data can be misleading, data can be restrictive, it all depends on data. If data is not given properly, your output is wrong, so always base your decisions on clinical acumen, your thinking. AI is just an addition to your brain. It is not going to replace, it is not going to change anything drastically. That's what he said to me. So I think that is what I feel now. We should acclimatize to AI, but not over-rely on AI.
So anybody else in the public? Yes, Srinivas.
Dr. Krishna Kumar, sir.